Realize, sir, we can start.
Good morning and Jai Hind everyone. I, Dr. Amit Jaiswal, welcome you all in today's scientific meeting of UPORTHOCON 2021. Today's first session is on acetabular fracture and the panelists are Dr. Nadeem Farooqi sir, Dr. Manishi Bansal and Dr. Ravi Gav. Without wasting much of my time, I would like to invite Dr. Vivek sir to deliver his lecture on percutaneous fixation of acetabular fractures. Over to you, sir.
lecture शुरू हो गया स्माइल
Can I start now?
Yes, sir.
Yeah. Thank you. Thank you, the organizers of UPCon 21 for inviting me and for giving me this opportunity to be speaking on one of our favorite topics and fields, which is acetabular surgery. I'll be speaking on a new topic, which is a percutaneous fixation in acetabular fractures. First of all, let's understand that open reduction and internal fixation remains the gold standard for all displaced acetabular fractures. Our aim is to do an anatomical reduction with a gap of 2 millimeters or less. Why? Because anatomical congruency gives us a very good joint function and reduces the risk of post-traumatic osteoarthritis. So this thing does not go anywhere. This remains the same. It is the gold standard. But there are some disadvantages. And the main disadvantages is when we use a huge approach and a dual approaches many a times, it increases the morbidity, causes the neurovascular injuries, can cause. We have blood losses, which are in extremes. HO formation, infection can happen. And sometimes in elderly patients, you can have poor wound healing as well. So that gives us an opportunity to explore the percutaneous approaches for such acetabular fractures. And as we feel and understand that percutaneous approaches are going to give us less complications, but the geometry and the three-dimensional anatomy of acetabulum can make it quite a challenging procedure for fixing these fractures through a percutaneous approach. What are the advantages? It limits the soft tissue disruptions, and also it can reduce the length of surgery and blood loss when compared to open reduction. But the moot point still remains that can we reduce and get anatomical congruency? Because our goal is to get anatomical congruency. So where does the indication for doing this percutaneous fractures and fixation lies? So the indications for them include non-displaced or slightly displaced fractures. That's the thing which we all need to understand, that right now the percutaneous fixations in acetabular surgeries is limited only and only to undisplaced fractures or slightly displaced fractures, which can be reduced by giving traction. You do not do that in a widely displaced fracture, saying that we are doing percutaneous fixation, which is going to be beneficial to the patient. In obese patients, very high, there you can try to achieve the columnar fixations of the far column, the other column. If you're fixing from one side, then you might fix from the opposites for the other column also from the same approach. And that can also be considered as a less invasive approach for the second column. And many a times, the indication which has increased now for the percutaneous fixation is in elderly patients and osteoporotic patients as a bone stock procedure, which means that you are preparing the columns to get united to each other, let them come together to each other, so that later on when you are planning and then total hip arthroplasty is inevitable, at that time the soft tissue disruptions will be less, the bones would have united, and then you can get in and do a relatively simple total hip replacement as compared to a complex revision sort of a replacement when an open reduction has been done. So right now, the two main indications for percutaneous fixation remains non-displaced or slightly displaced fractures, especially the columnar fractures. You don't fix the posterior walls with percutaneous fixations invariably because the articular congruency is the main indication for operating posterior walls. And the second main indication for doing a percutaneous fixation is in elderly patients, in columnar fractures, where you want to preserve the bone stock, maintain them so that you can get in and do the total hip arthroplasty in a relatively virgin sort of a approach. So now I'll deal mostly and concentrate on two major fixations which we do of the columns in a percutaneous way, and I'll show you how and why, what are the ways by which you can do these fixations. And then I'll also show you one or two, if time permits, the reduction screws and the other screws which can be put both percutaneously and while you are doing a surgery in a different way, in a minimally invasive way, which helps to hold the other column. So first of all, let's see how we can put and fix the posterior column in a percutaneous manner. When you are doing it, usually you do it in a percutaneous manner is in retrograde fashion, which is from the ischium, you go towards the ilium, rather than when you are opening it up and we are opening, you are going from the ilium towards the ischium. So a retrograde screw for a posterior column, let's understand that if this is a posterior column fracture, which is going on to the back side, you are going to fix it from the ischial tuberosity. The screw is going to go towards the iliopectineal line and going to go in a retrograde fashion. And if we look from an obturator view, it is going to go from the ischial tuberosity towards the pectineal line. So what and how? As I said, you usually do it in an undisplaced or mildly displaced fractures where you need to get compression. The displacements are not much. So you take first an iliac oblique view, try to find both the cortices of your ischial tuberosity. As you can see it here, there's a triangular shape, and right in the center of that triangle on the lower tip, you are starting to put in your guide wire. And then you need to maintain it both from away from the joint and away from the sciatic notches into the posterior column through an image. The second view which you look at as at an AP view, where it should be lying lateral to the teardrop inside the joint, because that's where the posterior column lies and you are lateral to the iliopectineal line and as well as ilioischial line. Then you are seeing that you are going right up to the greater sciatic notch area. Then you look at your obturator view. And in an obturator view, you find that your screw is going right in between the two triangles or the medial and the lateral border and the cortices of your sciatic buttress. So your screw is going right into the center there and is not coming out from any of the cortices. You put in a guide wire first, and then you can fire in your 7.3 or 8 mm screws. And then you are again looking at your iliac view to find that you have tightened it right on the ischial tuberosity. Because remember that ischial tuberosity, you just go medial to it, because if you are sitting, you don't want your screws to be pushing onto the patient's ischial tuberosity and causing him pain. Now let's come to the anterior column screw. The anterior column screw can be put in two ways. One is an antegrade way coming from the outer side to the medial wall, and the second one will be seen later on, which is a retrograde fashion. So in the same case, this is how we did it percutaneously for both the retrograde as well as the percutaneous anterior column screws. You first mark with a K wire where exactly you want to go. You see in with a K wire which is put on the skin where you are going, and then you like to look at the entry point. That entry point can be marked both in an obturator oblique view as well as in an inlet view. Remember, your two views which you look are obturator oblique and inlet views, and then you put in your guide wire, both in obturator oblique and inlet view, looking that it is going inside the pubic rami and above the joint. And then the screw can be pushed onto that, both in AP, in an inlet and an obturator oblique. So this is finally how you get the iliosacral screws were also put, but that comes in a pelvic surgery, so I'm not detailing that in percutaneous fixations. So this all was done in a percutaneous fashion for this patient, and you can see that the posterior column and the anterior column in a slightly displaced or mildly displaced transverse sort of a fracture were fixed in a percutaneous fashion. In all the views, you can see how they can look. And this is his final picture. You can see that the things have united, and in relatively minimally invasive way, we have been able to get a good fixation for the patient without much surgical morbidities. Such things can also be done if you want to do it in an open fashion, but remember that in such displaced fractures also, the same sort of plans can be done, and you can put in these screws into the fractures. Similar fixations have been done. This was the retrograde screw, which you put for the anterior column. And once you are putting these screws, you need to ensure that you are going below the pubic tubercle, inferior to it. You open the thing from the below the inferior pubic tubercle, try to go above the joint, and same views, obturator oblique view and inlet view, are going to give you the picture of going in above the joint right up to the thing. But mostly for anterior column fractures, you try to go in a antegrade fashion, and for the pubic rami fractures, which are closer to you, you want to go in a retrograde manner. How to choose which one, retrograde and anterior grade, as I said, on the fracture pattern and also on the musculature and the curvature of the ramus. Soft tissues and oscillating drills should be used. Reduction, you can open up slightly, use a joystick, put in a shank pin if required, or a ball spike pusher, or a Steinman pin to achieve the mild reduction which you want to get while fixing these fractures. Which screw can be put? This is a study which we published in International Orthopedics regarding the anterior column morphometric analysis, published in 2019 and 20, where we were able to show that only 54% of our cases of more than 300 CT scans were able to get 6.5 millimeter screws properly with 2 millimeters of leeway on either side. So you do not, in an elderly, in a female patient, you may not get an anterior column screw which is more than 6.5 in many of the cases, while in males you can get 7.3 screws. Preferably people put in 4.5 or 3.5 screws to get these fixations. I'll just end by saying that percutaneous fixations are the recent advancements, and you can fix the anterior column and the posterior column through them, provided they are undisplaced or mildly displaced, which can be taken care by traction. In elderly patients, which do require a total hip replacement, you can get in and fix them in a slightly malunited position because you want the bone stocks to consolidate so that you can go in for a replacement. Remember, thorough knowledge of the three-dimensional anatomy and the soft tissue is paramount. All your vessels, all your nerves are lying just adjacent to each other in these screws. So you better be knowing that thing so that you know how to open it as well if any untoward incident happens. Reduction, as I said, is a prerequisite for all these percutaneous fixations. Good imaging, I would say, is the most important thing. You need to have a good image intensifier, at least a 12 inches diameter image. Don't take a 9 or 6 inches diameter because that's not going to show you the pelvis in true sense. You should have a 12-inch diameter image intensifier for doing and venturing into these percutaneous screw fixations. Thank you very much.
Thank you, sir. Now the questions are invited from the audience.
Amit, the questions are in the end after the 4 talks.
Okay, okay. Thank you, Vivek, sir. Now I request Dr. Ramesh Sen, sir, to deliver his lecture on the management of posterior column fractures.
Hi, good morning. I anticipate the screen is visible to everybody.
Yes, sir.
So I'm thankful to the UPORTHOCON organizing committee to have given me the opportunity to talk about acetabulum fractures here. So here my focus is on the posterior column fractures. In the posterior column fractures, we perceive that we are talking about the part of the acetabulum which primarily takes care of the load. If you look at the weight-bearing dome and the posterior part of it, most of the weight-bearing area lies with the upper part of the posterior column. That's very important. And we know about the lateral classification in which posterior column involves the posterior part. And what is particularly for this part is that this has no association with any other structure. Once fractured, it is a free fragment in contrast to the anterior column, which might retain its link with the symphysis to the opposite side or to the upper part of it. Posterior column becomes a totally free fragment, and in that condition, it has got a displacement which could be much more than any other displacement in a given fracture scenario. Depending upon the force, whether it is caused by a dashboard kind of a injury, it can be shifted medially, and then there could be a rotational element depending upon the kind of force. If it is a classical injury with the hip abduction, it might rotate externally, and depending upon the kind of position of the limb, it might have a neutral rotation or internal rotation. But whenever it is associated as a part with anterior injuries, invariably it is internally rotated. The anterior injury, it can be associated, include anterior column with the posterior hemitransverse. It could be a part of a T-type fracture, or it could be a part of an associated both column fracture in some of the cases. So we need to understand that displacement is a very important thing which must be reduced. So classically, when we see a classical posterior column, obviously the things are very well defined on X-rays and on a CT, and we can very well lay them off that what are the fracture pattern, a line going through the dome area, going down to the obturator foramen. And we know about the classical injury in a classical posterior column fracture, a kind of a dashboard injury, which it is likely to lead to. But as I said it, the extent and the comminution part will also be affected, and it can be the combination involving the posterior wall in addition to the posterior column, which must be appreciated and has to be taken account in the reduction. The classical approach for a standard posterior column fracture remains Cocker-Langenbeck approach, which gives us adequate access into this area. And definitely it is recommended that when we are doing a posterior column, it must be done in a prone approach. Because in a lateral approach, if you are doing this posterior column fracture, the displacement can happen due to the weight of the head on that side, and we will have to apply those forces to reduce. But if the KL approach is done in a prone position, the reduction becomes automatically perfect because the weight bearing, the gravity forces are not acting over that. And once it is not there, even the retraction of the posterior column for stabilization also become easier. So whenever we are doing a posterior column, primarily, it should better be done in a prone position. And the next part of KL remains standard. You cut the rotators, you get over to down into the capsule area after cutting these rotators, and then you are over the fragment. Whenever we have to look at the fragment, we definitely have to be careful about our retraction in the greater and lesser sciatic notch. We have to be very careful to prevent the sciatic nerve injury at that point. Usually, we do not need trochanteric flip osteotomy in a posterior column fracture until unless there is a specific need for the additional comminution. Most of the time, we can do without it. We don't usually need a Gibson approach also, but definitely Gibson added to the posterior part dissection, we can get a better access to this posterior column. But very important, as I said in the start, and the mechanism also is understanding the rotation. And we must derotate and we must bring, while a hook can be used to reduce the displacement, we might invariably need a pin into the ischium to get that rotational element corrected. And that's a very important step after in this reduction procedure as such. And thereafter, once it is done, we can apply Farabuff, we can apply any other clamps to get that reduction achieved and then maintained definitely by a plate. And all those reduction tools are definitely very helpful in this kind of a situation. And whenever there is a combination of a posterior column with posterior wall, which is reasonably common, we have to reduce the column. Now, this is a pure column fracture which has been reduced, the lateral traction pin, and subsequently we tend to apply minimum of 2 plates so that no rotational strain remains over that fragment, which can be there if we just apply 1 plate. So 2 plates, one along the column, one along the wall, is advisable in this kind of a situation. And whenever there is an associated wall fracture, we have to reduce the column first, and then we have to come over to its reduction. That's important. Just like here, you reduce the column and thereafter you buttress the posterior wall in this kind of a situation. Another case, a posterior column in the wall fracture, you reduce the column and thereafter you come to the wall fracture reduction. These are the standards outcomes. Now, posterior column, as I said earlier, can be a part of other injuries like anterior column posterior hemitransverse, T-type fracture, or associated both column fracture. And here, because our primary approach is anterior, which could be any of the anterior approaches, we need to understand that the posterior column will be accessed after we have reduced the anterior column. So once anterior column is reduced, we have verified on the image its reduction is achieved, then we will have to go to reduce the posterior column. And if it is there as a part of it, we may use a hook so that it comes back to its own position. And in that situation, now comes fixation. One way is that through the same plate or around the plate, we can put screws from the anterior side to the posterior side, the longer screws, which can hold the posterior column in its position. But a standard way which is considered is passing a classical posterior column screw, which is passed about a 2 centimeter anterior and lateral to the this sacroiliac joint, from where we go parallel to the quadrilateral plate and enter into the area to put a screw into this kind of a situation. And this screw gives very good stabilization for the posterior column in this kind of a situation. In a case of a more associated injuries along with it also, this way we can stabilize the injuries and then we can pass a classically screw into the posterior column to stabilize that posterior column. And this is the subsequent follow-up of that patient. Now, as Dr. Vivek has just told about, other possibility of stabilizing posterior column is by putting a retrograde screw. And when it is combined with the anterior column as a posterior hemitransverse, this is one of the options that you stabilize the anterior column with the plate. And if you are not able to achieve or the fracture is much lower down, you can go with the retrograde screw application into the posterior column. Another method, and especially if there is a comminution of the posterior column, in that kind of a scenario, plate buttress is better, because the plate, the interfragmentary screw will depend upon non-comminuted situations where it can give a good interference. The plate can technically help in this kind of a situation, just like here in a T type of a fracture, a buttress plate can reduce and stabilize the posterior column fracture like this is, and this is the subsequent follow-up of that patient. Another kind of a pre-bent plates are also likely to buttress the posterior column in this kind of a situation by application from the anterior side. As you apply, things can be reduced, and this is the subsequent follow-up at 6 months. This is another case, another plate which is again a pre-bent plate can help in this kind of a reduction. This is 2 years follow-up, and this is his 8 years follow-up of having that reduction maintained. Now, the same thing can be done even from the AIP approach, which is much in favor now for its advantages. We can get the reduction of the posterior column, and then we can apply a plate along the posterior column. If it is comminuted, plate is supposed to be better. And in this kind of a situation, this plate, which is applied posterior column, gives a very good buttress at this part. And biomechanically, if you look at it, this is one of the biomechanical studies. Say that when you compare a plate with a screw, screws are better in point of a stability as far as it is concerned, but otherwise, depending on the fracture comminution, we have to adjust. So the take-home point is that posterior column can be alone fractures, and then they are very standard to be done by a KL approach, and it's better if it's done in a prone position. But whenever posterior column fractures are associated with anterior acetabular injuries, we have an option to go from the anterior approach only, and there are various methods in which, if it is a non-comminuted fracture, we should go with the screw fixation, and that screw has to be from the lateral window. And if it is a comminution fracture, we can use a buttress plate, and it can be from the AIP approach, or it can be from the lateral window, or from the ilioinguinal approach. Thank you.
Thank you, Ramesh, sir, for your wonderful lecture. May I invite Dr. Abhay for his lecture on the management of anterior column fractures.
Good morning, and
Thank you very much for the invitation on behalf for the UP Orthocon Organizing Committee. Is my screen visible?
Yes, sir.
Okay. So coming to the management of anterior column injuries, what we need to define in these next 10 or 12 minutes is how do you define the anterior column? We need to classify the column injuries. We need to define the indications of when to go in and the timing of when to operate, the approach and the different aspects of the approaches which we can use to access different fracture configurations, the reduction tools and toys, the fixation issues, and then essentially the long-term outcomes, because that is primarily what is most important. So the anterior column, as we all understand, can involve part of the symphysis pubis, the tubercle, the superior pubic ramus, the anterior wall, the anterior iliac psoas gutter, the root of the pubis, the anterior inferior iliac spine, the anterior superior iliac spine, and the iliac crest. And basically, dependent upon the type of anterior column fracture, one will have a variable degree of involvement of the articular margin, which is usually the anterior wall or the anterior articular margin. The important bit is how do you classify anterior column injuries? So they can be of essentially 4 types: the very low anterior column injuries, the low anterior column injuries, the intermediate anterior column injuries, and the high anterior column injuries. And there are some special variants. So the low anterior column injury is essentially where you have almost just a 10 to 15% anterior cornu involvement. The low one will have a fracture going through the iliac psoas gutter, and it involves almost about 30 to 35% of the articular margin. The intermediate one goes and exits into the at the level of the anterior inferior iliac spine, or between the anterior superior and the anterior inferior iliac spine. And the high anterior column fractures are those which will exit at the iliac crest or on the crest at a variable position. And the most common denominator of all these column injuries is that there will be an extension of the column into the ischiopubic ramus, and that can be dependent on the quantum and the direction of force transfer. Now, there are some special varieties. This is not exactly a pure anterior column injury, but just to highlight the special one, there are injuries which start from the anterior superior iliac spine or slightly higher, and they will exit not in the ischiopubic ramus, but at the level of the superior pubic ramus. And sometimes some of these injuries may be incomplete, which may require the completion of the osteotomy and completion of the break in the column so as to be able to derotate the column into its perfect anatomical position. So to classify an example, you draw the classical ilioinguinal, iliopectineal, and ilioischial lines, which will tell us which will eliminate certain types of fractures. Then we look at the ischiopubic ramus, and then we look at the iliac crest, which will define for us that this is an anterior column injury. The indications and timings essentially is a statement of the extent of the joint which is involved. So the very low anterior column injuries may actually be conserved. The low, intermediate, and the high anterior column injuries and the variants need to be surgically treated, and that is absolutely important for restoration of a perfect anatomy of the acetabular socket. And then it is important the next most important message comes from the survivorship statements of acetabular fractures over 30 years. And those essentially mean that initial displacements of more than 2 to 3 millimeters, you need to reduce and fix surgically. And a treatment delay of simple anterior column, anterior wall fractures, either isolatedly or in combination, if operated within the first 14 days, the quality of reduction and fixation is very high, almost to the tune of 80 to 90%. And if treated beyond 14 days or 3 weeks, the quality of reduction tends to suffer. So actually, if you need to go in to fix an anterior column fracture, if it is indicated, you need to go in the first 2 weeks for better quality of reduction and ease of fixation. Now, the approaches that one can use to access the anterior column can be a combination or can be in isolation. So it is the standard gold ilioinguinal approach, which accesses both the false pelvis as well as the true pelvis. You could have the iliofemoral approach with its modification, that is the anterior superior iliac spine osteotomy, which will give wonderful access to the anterior column up to the level of the root or the iliopectineal eminence. And in certain cases and with experience, you are able to fix a lot of fractures with iliofemoral and a modified iliofemoral alone. The intrapelvic or the access through the false true pelvis comes through the AIP or the anterior intrapelvic, which has gained a significant amount of importance in recent times, and the pararectus approach. So the reduction tools and techniques that one needs to consider, and the certain specific ones that are very important in the armamentarium are the Marta's asymmetric clamps, the ballpoint pushers, the oblique forceps, the Farabaug's clamps, and the Youngbluth clamps. And of course, the reduction forces of Weber's are very, very important. Sometimes you tend to use Shan's pins as reduction tools, as well as plates as indirect reduction tools as well. So that's an example of certain clamps and reduction toys that we use on the table. So that is an asymmetric Marta clamp, which is used for fixation of the anterior column in a certain situation, not just an anterior column involvement. That is the that's another clamp which you can use to guide through the reduction, reduce the column, and fix the fragment. It's the collinear clamp, which is a very, very, very good tool and a very powerful tool to reduce the anterior column to the anterior column as is seen above, or the anterior column to the posterior column as is seen below. The Youngbluth clamp is a fantastic tool because it allows reduction in 3 dimensions, and it's a great tool. The only problem may be that the space available in the column may not allow the Youngbluth clamp to be used at all times, but it is a fantastic tool, and in especially delayed situations, it's a great tool to reduce, and it allows you to do a perfect anatomical reduction. The Weber's forceps is an excellent tool. It helps to reduce the column, but the slight limitation of the Weber's clamp is that you can reduce the fracture only in 1 or 2 dimensions. Certain direct compression devices are excellent reduction tools, as you see here, that sometimes even a Hohmann can be used as a reduction tool. The plates can be used as excellent reduction tools, as an indirect reduction tool, because they buttress the fracture, and then you can put in lags to the anterior column through the plate, and that's an iliofemoral approach. The ballpoint pushers are fantastic reduction tools, and they help you in reducing the fractures. So you use whichever toys you can use on a given situation based on the fracture configuration and the approach used and the anatomy that is disturbed. Another very important part is restoring the anteromedial dome impaction, and that happens in certain anterior column, not purely so much in pure anterior column as much as in the other combination injuries where you need to restore the dome fragment, put it back into position, restore the alignment of the displaced dome fragment, and put in a buttress fixation there. So those are certain situations, especially in the intermediate and the high anterior column injuries, which can need that kind of fixation. Now, to fix the anterior column, it is important to understand that the pelvis is a confluence of 3 right angles. One is the ilium, second is the acetabular socket, and third is the pubis, and they are all at right angles to each other. So it is extremely, extremely important to understand, as Vivek and Sensor also pointed out, that you need to understand where you can put in your fixation devices into the pelvis. And those are the iliac crest, the supraacetabular canal, the infraacetabular canal, and the superior pubic ramus, as the posterior column will require the posterior pathway. The certain techniques can be percutaneous or minimally open techniques using screws and screws after reduction with clamps. You can use the iliopubic screws, you can use the LC2 screws, you can use the ilioileal screws, you can use the screws infraacetabular and supraacetabular, and the magic screws either separately or through the plates, as also been demonstrated and has been shown in this particular situation where the anterior column has been reduced, and the stabilization of the posterior column also has been done with limited screw fixations. So coming to the pure column injuries, the very low anterior columns, usually they can be isolated or they can be part of a symptom complex. 80% of the articular surface is involved or the rim is involved. So these are fractures which are not usually included by Letournel in fractures requiring reduction and fixation. They are isolated injuries which can be conserved, but the pelvic injury and the acetabulo-pelvic combination injuries need to be treated as per the extent of the pelvic ring damage. Coming to the low anterior column injuries, these are injuries which involve 30 to 50% of the articular surface. They need anatomical restoration to avoid focal loading. You can use a modified iliofemoral with an ASIS osteotomy or an AIP or an ilioinguinal approach, whichever you are most comfortable with. The reduction techniques are as they are used for the anterior wall fractures. And the sequence of reduction usually is the reduction of the hip joint, and the identification of articular margins, restoration of marginal impactions, and restoration of the main acetabular fragment, which is externally rotated and thereby fixating. So another patient, similar injuries, anterior column, you can have the intermediate or the intermediate or the high anterior column fractures. Now, these essentially are fractures where the number of fragments will dictate how you will reduce this particular injury. It is important to understand that the anterior column is externally rotated. Again, you can use the approach which you are most comfortable with. The anterior approaches, there are three which are very, very popular. The classical concept of reduction is proximal to distal. You have to reduce the iliac fossa, do a temporary fixation of the crest, reduce the main column fragment, and fixation of the buttress. So that's not classically a pure anterior column injury, which was reduced and fixed by a modified iliofemoral approach alone, and the dome has to be centered, the head has to be centered perfectly under the dome, and it allows a stable fixation. You can have wall and column combination of injuries, which essentially mean that these are segmental anterior column fractures. The size of the wall and the type of the anterior column injury will decide what percentage of the articular surface is involved. Again, the approaches can be either of the three, whichever one is comfortable with. And the reduction and fixation sequences are as per the geometric configuration of the wall and the columns. So another example here where an anterior column, anterior wall fracture was present, wherein both the fractures were reduced with an ilioinguinal here. The reduction is congruent. And to finish, I would like to summarize by saying that anterior column fractures can be very low, low, intermediate, or high. The fracture involves a variable amount of quadrilateral plate, which has to be addressed either by open methods or by percutaneous methods as per the geometry of the fracture. The ilioinguinal, the stopper with lateral windrow, and the modified iliofemoral approaches are very, very good for accessing these particular injuries. Reduction of the isolated or the segmental anterior column fragment, which is externally rotated, is critical. Reduction through clamps in the middle or lateral window or buttressing with spring plates or intrapectineal plates is an option and a very useful reduction tool as well. And pelvic brim plate has to be of adequate length to stabilize and buttress the fracture adequately so as to prevent shear forces. Thank you so much for your time. So at the end, before we just finish, it is extremely, extremely important to reiterate that irrespective of the kind of fracture, the most important survivorship determinant remains that the head of the femur is congruently relocated under the dome of the acetabulum. And that is the only thing which will give back a very good long-term functional outcome. Thank you.
Thank you, Abhay sir, for your such an informative lecture on the management of anterior column fractures. And now I invite Dr. Prasoon sir to deliver his lecture on tips and tricks in quadrilateral plate fixation.
Thank
Dr.
you.
Prasoon, sir.
I hope my screen is visible. Can you see my?
No, sir, it's not coming.
Just a minute.
Yeah.
I'm just trying to. Can you see it? Can you see my presentation?
Yes, it's coming now.
Yeah. Good morning, delegates, and a very happy morning to all of the delegates who are awake for this acetabulum session. I will be presenting a simple and no-frills presentation on the quadrilateral plate management. Some of the things have been covered by previous speakers, especially Dr. Ramesh Sen. So whenever we see this X-ray in which the head has gone inside the pelvis, none of us like it very much. The more the head goes inside, the less we are, enthusiastic about handling these fractures. What are the problems? The problem is how to expose these fractures. The anterior exposures, we are not exactly very comfortable. How to get the reduction? Frequently, this head is not reduced. This cortilateral plate gets broken. And even if you have reduced the fracture, the methods, the plate, the spring plates, whatever you apply in the postoperative phase, many of the cases, the head still goes inside. So these are some of the challenges. So obviously, currently the gold standard for managing this type of pattern is topaz. Obviously, it gives a better exposure of cortilateral plate compared to ilioinguinal or a modified iliofemoral. Some of the things which can make our life easier is that when you position the patient, you can apply a bolster below the knee, so your hip is flagged, so it will relax the rectus. The most important thing is to put a 6.5 Shank pin in the femur head, so you can put a lateral traction. That is the single most important thing, and adequate muscle relaxation. I will not describe scope in detail, but some of the points which can help in the exposure is frequently the vertical splitting of the rectus is inadequate. We have to remember, we have to release it proximally adequately so that it is retracted properly. Second, we can partially erase the broad insertion of the rectus on the symphysis, so that it is easier to retract. In fact, it is one of the reasons that why pararectus is coming, because rectus does create a hindrance in our exposure. Now the stopa is simple. You start from symphysis pubis and go towards the greater sciatic notch or sciatic buttress. Obviously, everybody is now very familiar with the corona mortis and we ligate it. But the more problematic thing is in the posterior part, the external iliac vein. If you see the literature, the major problems or major injuries happen to external iliac vein, which is difficult to control. So one has to be very careful. I will also describe it in detail. And the second thing, as the specialized plates are coming and they are dipping more and more deep in the pelvis, this obturator vein, it can also get injured when you are trying to put all these intrapelvic plates. So we have to keep aware of this obturator vein and external iliac vein beside the corona mortis. Third thing is the placement of retractors. Obviously, not everybody is having the specialized retractors, the lighted retractors. So you should have availability of at least malleable retractors for that area in which you are retracting the abdominal viscera. And I have emphasized that the rectus insertion on the symphysis, you have to partially erase it so you can have a better exposure. Obviously, the first intuition is whenever you're trying to reduce the head which has gone inside is to push it back, or to put all these clamps and try to reduce the quadrilateral plate. You can see that there is also a disc over it, but frequently if you do it alone, the quadrilateral plate is not reduced or it breaks. So the main strategy should be pull and push. The shine pin should pull. The major component of force should be the pulling, and it should be supplemented by the pushing, not vice versa, because you cannot push the head out. You have to pull it out with a 6.5 inch shine pin, not even a 4.5 inch shine pin, because it will bend, and then gently push. If you are having obstacles in pushing or reduction, as in old cases, you have to reevaluate your strategy. I will again emphasize it. So in this case, we have a multiple clamps which are pushing, we are pulling, and as you can see, this thing is pushing the quadrilateral plate back. So obviously the first maneuver in this is to reduce the anterior column, put an anterior brim plate, and then once it is reduced, there are many methods to maintain the reduction. One is the leg screw, which Dr. Ramesh and Dr. Abhay has emphasized, in which you can put the leg screws. Now the major workhorse is the intrapelvic fixation, because it directly counters the inward force of the femur head. So this plate typically starts from the sciatic buttress to the anterior part. It is a typically 8 to 9 hole plate. In the posterior part, you get 2 screws, good screws in a very dense bone. A very good fixation is there. And once you come anteriorly, the major problem happens because there is abdominal viscera. Unlike this bone model, your drill will not be able to go through the holes because they are not 90 degree. So you have to superiorly rotate your plate. This is a photograph in which we seeing the two posterior screws going to the greater sciatic, not the sciatic buttress area. This is the problematic part. So in this area, it is difficult to put a screw with a straight drill bit. So you have to gently rotate it upwards. So when you are putting the drill, you are able to drill it, because not everybody is having the flexible drill bit. And this is the brim plate. This is the corona mortis, this is a brim plate, this is your infrapectineal plate. And obviously, one more thing, it has to be very well contoured, in fact, to the extent of over contoured, so it is able to put a force on the quadrilateral plate. You can also use this plate as a gentle adjunct in reduction when you apply it on the sciatic buttress, and when you are putting the anterior screws, gently it can help in reduction, but you should not rely it as a sole reduction strategy. As you can see, this is in the two screws you can get in the sciatic buttress and two anterior screws. Now, if the quadrilateral plate is comminuted, so frequently you have to apply a second infrapectineal plate also. So where you can apply it? Frequently, the starting point is in the sciatic buttress. You can run it down towards the ischial spine in this area, and or you can run it towards the obturator foramen area. This is an example where a second plate, a 2.4 mm T plate, has been applied on the sciatic buttress area, and it is going deep in the pelvis. There are many specialized plates which are coming every day. Company launches in India, they are not so freely available. And as you can see, there is a proliferation. They are going much deeper and deeper into the pelvis. So first of all, there is a problem of contouring, because the diameter of these plates and Indian pelvis has to be matched. So they may not match, or they may not fit on the pelvis perfectly. And second, all these holes can be put the screw safely. So we know this central area, the quadrilateral plate, you cannot put any screw. So where people are putting a screw, one strategy is they are putting a screw more anteriorly towards the obturator foramen area. But as we know, if you are putting screws in this area, then you have to safeguard your obturator vascular bundle. And frequently you have to clip it, because you don't want any hemorrhage to occur here. In my view, the safest thing is that you start on the sciatic buttress area and come towards the ischial spine, where you can still put it safely and without any major structures. Now, can you do stopper in every case? Unfortunately not. The one anatomical division is a low division of the external iliac and internal iliac. If it is low, you cannot access the sciatic buttress safely. And that is the reason that many people have external iliac vein injury. And vein injury is slightly tricky injury to handle. Even the CTVS person, they will say, rather injure the artery rather than injuring the vein. Second thing, in many of the patients, we have got adhesions, previously operated abdominal surgeries, and where ladies with cesareans, they can have adhesions. And second, the old cases. Typically, if your case is more than 12 to 14 days old, when you are doing stoppers alone, it can be tricky. So in those cases, the current dinosaur, the ilioinguinal approach, you should add. Because in 10 to 15% of cases, in my view, when you are doing stopper and if you are encountering difficulty in exposing this area, you should not be rigid, because you may injure some vein. So in this area, you simply develop the ilioinguinal. It is very fast, because you already cleared the iliopectineal fascia. So the major time-taking step in the ilioinguinal is gone, and you just convert to ilioinguinal. And with ilioinguinal, you can have a finger palpation of the quadrilateral surface. You can put screws, you can put this spring plates, and still can manage the quadrilateral plate. Now and you can see this leg screw which is going here. This is a plate. The major problem with the spring plate, if you are making it yourself, it does not sit on the quadrilateral plate. If you see the previous example, the plate is exactly not sitting. It just, lifts away from the bone. So it is better to have a 1/3 semitubular plate and you bend it eccentrically. If you bend it perpendicularly, you cannot. And then you make an angle of almost 90 degree minus 15 degree. And then you apply it, then it is likely to fit. Obviously, pre-contoured plates are now available in which there is also a screw to lock the things, but they are not exactly available all the time. And this screw which the current company which is available in India is promoting, it is also by a finger palpation. It is not exactly through a zig. So you can obviously fidgety to put this screw through this slot. If your case is more than 2 weeks old, and when you are doing an NTA approach, and your quadrilateral plate is not getting reduced, obviously you know there is a fibrous or callus tissue in the posterior column and this. So you obviously cannot forcefully reduce this quadrilateral plate. It will simply break. So you have to just fix the anterior brim plate. You have to come posterior. In my view, you use the jung cloth clamp. You have to distract this fracture, clean the fibrous tissue, callus tissue very thoroughly. You have to then feel the quadrilateral plate reduction by your finger. Obviously, it is only possible in prone position. And in prone position, only the head's medial push will be neutralized. Then typically, these clamps are put in the pelvis. I personally do not like to put these clamps blindly into the pelvis because I'm afraid about the vascular structures. I will rather use this heavy-duty clamp, that is jung cloth clamp, in which you can first distract the fracture, clean it, and you can also have a rotational reduction, check it with the finger, and then reduce the quadrilateral plate rather than putting big bulky clamps inside the pelvis. So this is the presentation. To conclude, Stopa is the current flavor unless it is replaced by Pararectus in coming years. Intrapelvic plating obviously is the most, I will say, the rigid thing to prevent the medial migration. And the second plates, the specialized plates which are coming, so we have to be more and more conversant with the safe zone of the screws which we are putting in around the quadrilateral plate area. It is an evolving field. Ilioinguinal, I think it is still has got a place in quadrilateral plate management, where you cannot safely do Stopa in old cases, in adhesions, in low divisions of vascular variations. You have to add ilioinguinal to the Stopa, which you have already done, and then do safely the quadrilateral plate management. Obviously, in old cases, a NTA approach may not allow the reduction, and you have to do an addition of posterior KL approach. Thank you for your patient listening.
Thank you, Dr. Prasoon, sir, for your such an elaborate lecture on the tips and tricks of the quadrilateral plate fixation. Now this session is open for question and answer. May I invite questions from delegates as well as from faculties, from chairpersons? Yes, sir.
Ravi has a question.
Yes. Sir, thank you all faculty for a nice presentation. My question to Dr. Vivek, what is the position of limb while doing the percutaneous ischioiliac screw?
Okay. The thing is that once you are doing a retrograde posterior column screw, what you need to do is you should have a radiolucent table. You drape both the limbs freely, and then you can have the patient in a lithotomy position, or you can have the patient in a flexed hip and flexed knee with abduction and external rotation, which is being held by somebody. That's the problem which you need to do. The other thing is to properly drape the anal area, because many a times it's very just adjacent to your anal cleft as well as the anal canal. So you need to drape and close it properly with a mop, and then only you will be able to feel the ischial tuberosity and then try to see that. That's it. You do not need any bumps or anything like that. Have a radiolucent table. Ensure before draping that you are able to see your inlet view properly, and other views, outlet, and all the other views are able to see. Put him in the lithotomy position. That's what you can do.
There is a question for Prasoon, sir. Can we do the ilioinguinal approach in all cases of quadrilateral plate fractures?
Until 10 years back, we used to handle quadrilateral plate with ilioinguinal approach only. obviously a comminuted quadrilateral plate, or especially in a elderly person who has got a quadrilateral plate with dome impaction, the stopa is better. So I will still say the preference is stopas. When you are not able to do stopas safely, then you should do ilioinguinal. But preferably the current answer is that whenever possible, you should go for a stopa and intrapelvic fixation. If you are having difficulties, you can convert to ilioinguinal, the windows, and can still do a safe reduction by leg screws and the spring plate, you can still do. But preferably now in the current 2021, the flavor is stopas and intrapelvic plating only.
There is a question for Dr. Vivek sir. Sir, when to select a case from percutaneous fixation and when to go for the open surgery?
Yeah, so I think I dwelt a lot upon that in the very first few slides. And that was the thing, that the indication for doing a percutaneous fixation is only in undisplaced fractures or very mildly displaced fractures, which can get reduced with traction in young patients. In the elderly, where we feel that the patient is having an associated both column or an ACPHT sort of a fracture, where the fixation alone is not going to give us good outcomes later on, then we do a bone stock procedure or try to consolidate the bones and let them unite in a position, maybe some amount of malunion as well, so that you can do the staged total hip replacement earlier, and you can do it with a simpler implants rather than using the revision implants or a cup cage scenario. So the two indications for doing the purely percutaneous fixations is an undisplaced fracture where the patient is young and wants to mobilize as early as possible. Else you will have to keep him on bed for 6 weeks, or in elderly patients where you want the bone stock to get consolidated early so that you can go in for a early total hip replacement.
One question for Ramesh Sen sir. Sir, what is the ideal time of the surgery for acetabular fracture or column fracture fixation?
Yes. Technically, again, as Vivek has time and again said, it is the displacement which must be reduced. So the ease of reduction is always within the first week. So ideally, when the patient has settled, as can happen on the third, fourth day, we must be able to operate from third day onwards till 6th or 7th day. That is the ideal time when the patient is also settled for the injury, and we can have the best reduction possibilities with indirect means, just like as Dr. Prasoon showed, by lateral traction given, most of the displacement tend to fall back and most of the manipulations are easier to do. So the ideal time is third day to 7th day.
Sir, what should we do? Suppose if in India, most of the time patients comes very late. They comes at the 3 weeks post-injury or 6 weeks post-injury. What should we do for a three weeks post-injury cases?
The changes which we may have to induce is that probably because the reduction abilities are decreased, and we have cases by third week, a soft callus starts forming around the fracture sites. So more comminuted the fracture is, more are the chances that we might have a difficulty in getting the reduction also. So our problem increase that we might have to more extensile approach. We might have to add on another approach to get the reduction done. So the difficulties will keep on increasing, but then we have to be ready, because the reduction of the articular surface is the most important thing. So we have to increase our dimensions of surgery, increasing exposure or increasing or adding an extra approaches will be the management at that stage.
Sir, there is one more question for you, sir. When would you prefer a primary THR for acetabular fracture in elderly?
My perception in that elderly age group is two things. First, because we look at the epidemiology, they don't mostly get posterior wall or posterior injury, which are high velocity injuries. They primarily get anterior injuries, and in anterior injuries, they frequently have got impaction also associated with it. So all those cases where there is a poor bone quality with a comminution and especially with the impaction will be my option for basic stability and a replacement in this kind of a situation. And then you can look at the comorbid conditions of the patient also, that if there are situations which do not get into the proper reconstruction mechanism, it's better to go for a replacement in the first go rather than getting the patient for a repeat surgery of a reconstruction for a replacement. So the fracture condition and the patient condition. Fracture, I am summarizing again, comminution, impaction, and a poor quality bone are the primary criteria. And sometimes we do have a arthritic hip, which will involve it, or sometimes we have got associated neck also impacted, which will definitely ask for it.
So there is a question for all the speakers. What are the long-term outcome of posterior and anterior column fractures despite anatomical reduction? Do we understand the cartilage injuries well today?
If I am to say, very important to perceive that posterior injuries are primarily the direct impact injuries to the posterior column and the posterior superior surface, which has got a cartilage, which in spite of anatomical reduction, likely to behave bad. And that is what literature is very clear about it, that even in spite of a very good reduction of the posterior column or a posterior wall, the outcome can still be bad as compared to relatively anterior injury. Now, good thing about anterior injury is that the dome, if it is not impacted badly, they tend to behave well if the reduction of the head is done under the articular roof. Because most of the injuries goes sometime out of the weight bearing zone also. It is the displacement, but the weight bearing zone remains intact. It's only when the weight bearing area is fractured and not reconstructed well, and there is an impaction which is not done well, then that will behave bad. So out of the two, posterior versus anterior, posterior, in spite of a good anatomical reductions, are the ones which will behave bad.
Can I say one thing on that
Yes,
as
sir.
well? As Sir has very rightly pointed out, the other thing that one must keep in mind, especially younger patients, is that once we have anatomically restored either a posterior or an anterior column injury, the longevity of that hip is far more, even if it becomes avascular. So that is extremely important, because we are looking at more balanced loading of the dome if you have done a very good reconstruction of the head under the dome. So that is of primary importance. The other thing is that, as Sir said, the elderly, that's a different ball game, where the parameters of how you look at and treat these injuries change based on the quality of bone, the degree of comminution and articular impaction. So the ability, especially in young patients, the reducibility, what we say, is a very important thing, that despite a very good reduction, sometimes the head may become avascular, but it still lasts. And there is something called an aspheric congruence also, which develops with minor articular malformations, which should be less than 2 millimeters. So that has to be kept in mind.
Thank you. Thank you very much, all the speakers, for your very elaborate presentation and wonderful presentation, sir. So time is short now. Now we are going to proceed towards the next session. May I invite Dr. Santosh Singh, sir, and Dr. Latif, sir, to take over the session. Dr. Santosh, sir.
Thank you, Dr. Amit. Thanks to all the speakers for this very good session. So now the next session is on the ankle injuries. So in this session, our panelists will be Dr. S.C. Goel, sir, Professor Vineet Sharma, sir, and Dr. T.P.S. Lama. Without wasting any time, I invite Dr. Anup Agarwal. Please say a few words and let us we start this.
Thank you, Santosh. I take this opportunity to welcome our esteemed faculty, Dr. Arvind Puri, who is a prominent foot and ankle consultant based in Cairnsally, Australia. He is also Secretary of Asia Pacific Foot and Ankle Society and one of the prominent name in foot and ankle. Welcome, Dr. Arvind Puri, for joining us at a short invitation.
Thank you very much for your kind introduction, Anup.
And we'll start straightway from your talk.
Sure. I'll share my screen.
So that is good for us that Dr. Arvind Puri is available with us for their expert comments and expert lecture. So Dr. Arvind Puri, you are welcome.
All right. Will I go ahead? Share my screen?
Management of syndesmotic injuries.
Manishi, can you mute yourself, Dr. Manishi?
Hello. Is it okay to go ahead? Is it all right to go ahead?
Yeah, please go ahead. Go ahead.
Thank you.
Well,
thank you very much, first of all, to Anup and Jamal for giving me this opportunity to present at the UP Orthopedic Association's annual meeting. It's an honor. And my brief is on the management of syndesmotic injuries. Now, we all know this is a very controversial topic and extremely vast. So I'm going to try and limit myself to what I think are the most important points one must consider when addressing these injuries, and briefly what my current practice is in relation to this ankle fracture. So we all know that the syndesmosis injuries can go from one extreme to another, and I think it is our primary responsibility to be able to identify this injury most, if not every time, and address it in the appropriate fashion. My first slide that I'm going to show you here is the three most important points which cause grief to the patient and us when we are dealing with syndesmosis injuries. So the first is the ability to recognize it. So 47% of reoperation rates in ankle fractures to fix the syndesmosis is because it has not been recognized. That's a big number. The second most cause is the reduction of the syndesmosis. Nearly 31% of reoperation rates in ankle fractures is because the syndesmosis was mal-reduced at the very start. And the third is the implant failure, which is a much smaller portion of the problem that is given to us in managing syndesmosis. So we have to really decide how many opportunities we have in identifying this injury before we fix it. And in my mind, there's 4 stages. The first one is the history and the mechanism of injury. By far, this is the most important. And it is quite important that you ask the patient in no uncertain terms if they can describe how the injury took place. Most of these injuries, as you know, are in the younger age group. There might be high energy trauma or sports injuries. But the most common description is that of the foot is stuck to the ground and the body rotates on it, causing an external rotation energy to the ankle and then resulting in the syndesmotic injury. So examination is the next part. It is not very helpful in the acute setting, but in the chronic or late presenters, it can be quite useful. Radiological investigations, I think, is the bedrock for trying to find out if the syndesmosis is truly damaged, and if it is, of what extent the damage has it sustained. And the last chance you will have to verify if the syndesmosis is intact or not is during the surgery itself. So if we miss all these 4 opportunities, the natural history of this missed injury is ankle arthritis, and then we have to deal with the consequences of that. And most often, this is a painful, unstable arthritic ankle which needs to be fused. So just a brief note on the anatomy. We know that the 3 most important structures forming the syndesmosis are the AITFL, PITFL, the interosseous, as well as a small area of the PITFL, which is called the transverse ligament. And all of these together contribute to giving the fibula or the syndesmosis the stability and prevent the fibula from going too far, translating in the coronal or in the sagittal plane. The other important thing to know is that the 3 main fragments to which these ligaments are attached can also be involved in the fracture and would be a very obvious sign that the syndesmosis is damaged. And we know that the anterior ones are called the Shaput, the Wagstaff, and the posterior one is called the Walkman's fragment. Just very briefly, the most important ligament is the AITFL to external rotation, followed by the other two. But progressively, as the energy is imparted, the syndesmosis tends to rupture. This is an important concept of the greater ring. Remember, the talus is at the center, and the ring around it is a combination of bone, which is medial malleolus, tibial plafond, lateral malleolus, as well as the calcaneus. The ligaments involving in this ring are the deltoid ligament, the syndesmotic, and the lateral ligament. And if this concept is kept in mind, then it's easy to look for what's damaged and then easy to reconstitute the ring as well. So these are the common mechanism of injuries, where the foot is planted on the ground, the player hits you while playing soccer or football, or much more dangerous sports like bullfighting, and really the whole body twists on the ankle, causing the foot to go into external rotation, the talus in eversion, and then finally the whole syndesmotic ligaments start to tear apart. The deltoid ligament is a very important part of this ring, and it always, if not the medial malleolar fracture, is involved partially or completely in the disruption of this ring. Clinical examination, essentially 3 tests. One of them is the squeeze test done in the middle of the calf, but this is a very non-accurate, highly unscientific, and perhaps the most or the least useful of all the tests. The second test, which is in the lower right-hand side picture, where the knee is stabilized and flexed to about 70 to 90 degrees, and the foot is then dorsiflexed and forcibly externally rotated, reproducing pain in the syndesmosis is more accurate, or the crossed leg, which is almost as accurate as the forced dorsiflexion and external rotation test. However, clinical tests are not that useful in the acute setting, but in the chronic setting, they can be quite useful. What about radiology? In my mind, X-rays are probably not that useful, and studies have clearly shown that the radiographic measurements for distal tibulofibular syndesmosis has great limited use. We are always told that we must look out for the tibiofibular clear space as well as the tibiofibular.
We lost it.
So, sorry, can you hear me? So remember, the Maisonneuve injury is not to be forgotten. So don't accept X-rays which only show you the ankle. Make sure you got the fibula included, and also be cognizant of which one is the modest view and which is the AP view. Gravity stress X-rays are good for deltoid ligament. Weight bearing X-rays bilaterally can also be useful once the patient is about a week or 10 days down the track. I think the most important aspect of ankle fracture with syndesmosis injury is to know about the Log-Hansen classification. This classification, which consists of 4 patterns of ankle injury, consists of the foot in the position that it was and the force that is applied to it. And the most important of these are the 3 X-rays on the right-hand side, the supination, the pronation, abduction, and the pronation external rotation. And these should alert you that there is a syndesmotic injury. If you see the X-ray on the left side, which is the supination adduction injury, it is invariably without syndesmotic involvement. CT scan is really accurate as long as there is a difference of at least 2 millimeters between the 2 sides. The MRI scan is 96% accurate and really shows you the extent of involvement or the destruction of the ligaments, as well as to some extent of the placement of the fibula in relation to the tibial incisura. During the operation, if you perform an ankle arthroscope, you should be able to pass a 3.5 millimeter shaver through the tibiofibular gap where the syndesmosis is easily, and that is quite confirmatory for an ankle syndesmosis injury. And the last way that you can test whether the synosmus is intact or not is the cotton test, where a hook is placed after you have stabilized the lateral and the medial side, and see if there is an increase in the clear space between the tibia and the fibula as well as the medial side. So the next most important thing is the reduction of this injury. Now, if you perform a closed reduction where you do not look or visualize the synosmosis itself, the clamp has to be placed in such a way that there is no evidence of any malreduction. And that involves putting the tongs of the clamp that you have used at the fibula and the tibia in such a way that the fibula is against the incisura of the tibia. And this means that the tongs should be placed about 15 to 20 degrees anteriorly to the coronal plane itself. If the tongs are placed horizontally or even in the opposite direction, it will result in a malreduced syndesmosis. This is my biggest pearl for everybody who's listening to this talk, is that I always open the syndesmosis anteriorly. Once you have made the incision between the tibia and the fibula anteriorly, just above the ankle joint itself, and you go down to, after preserving the superficial peroneal nerve and retracting the muscles, you land directly on the syndesmosis. And if it is ruptured, it is quite clearly so. And if it's not, you can try distracting it and see how much gap you have. And to me, this is another way not only of confirming, but also accurately visualizing the reduction of the fibula onto the tibia before you stabilize it. So again, going back to the greater ring, you have to make sure before you call this an ankle which has been stabilized, that you have taken into account the medial malleolus, the lateral malleolus, the tibial plafond if involved, and the 3 ligaments. And they all need to be assessed at the time of the surgery to be sure that the ring has been reconstituted. So what about stabilization, which is the third problem? Now, there is numerous studies that have been done about 1 screw or 2 screw or 3 or 4 cortices, a small fragment screw or a large fragment screw. And with these newer implants called the suture button implants, whether you put 1, 2, or a combination with screws. So my take on this is that the best way to do, if you are a believer of screws, then preferably 2 screws. It doesn't matter if it's the small or the large fragment, and it doesn't matter if it's 3 or 4 cortices. Studies have shown 2 screws are better than 1. And if I use screws, I always put them through 1/3 tubular plate, 2 or 3 holes, and that evens the pressure which is on the fibula and hopefully avoids having any periprosthetic fractures. Suture button, definitely more physiological. It allows movement of the fibula. You can put 1 or 2. I certainly put 2 if I've got a Mason-Nave injury, which is a far more high energy injury. But if it's an ankle fracture without Mason-Nave, I'm happy with 1 suture button. If my reduction is not satisfactory, I do supplement it with a screw, which I then take out later on. So these are the different ways of stabilizing. And my favorite way when I use the screws is the one on the left bottom with the plate, and then the one on the right where the suture button technique has been used. So my post-operative protocol consists of immobilizing these fractures for 4 weeks. Then we would move them into a removable back slab or a boot and start partial weight bearing. Mobilize the ankle joint at that stage, and maybe full weight bear at 6 weeks if I'm happy with the reconstruction of the ring around the ankle, followed by strengthening exercises. And I do not encourage return to contact sports up till 6 months' time. Thank you very much.
Thank you, Dr. Arvind Puri, sir. Now I invite Dr. Jamal to take his presentation on the management principle in pylon fractures.
You see my slides?
Yeah.
Okay. Thank you. I'll be speaking on the treatment principles in pylon fractures. Now, these are the key principles that have to be meticulously followed in order to prevent complications and get good, decent results. So, number 1, understand the problem at hand. Historically, treatment options suggested in literature have been quite confusing. This resulted in a number of studies being undertaken to try and outline the treatment protocols. And thanks to these studies, supported by scientific evidences, in recent years, our understanding of the injury patterns and mechanisms has greatly evolved. Now, to a young orthopedic surgeon, if I were to say, looking at these two clinical photographs, which injury appears to be more serious? And if his answer was that he cannot comment only on the basis of clinical photographs, he would be absolutely correct. Now, since he has both the X-rays as well as clinical photographs, does he think both these injuries are similar? Well, they most certainly are not. And that is where the importance of understanding the injury comes in. Staging protocols are important, and judgment is required. When in doubt about the surgery, it should be delayed, keeping in mind the most important aspect, and that is the soft tissue damage. It is therefore paramount to understand the extent of soft tissue damage. Soft tissue damage is the most important factor that will be the determinant of what you will do, when you will do, and how you will do. This dictates the pro's plan of management in each and every case, and this prompted Joseph Schatzker to actually comment that this is one fracture which is fraught with many difficulties, most significant of which is the soft tissue complication. And because of this very reason, currently there is a lot of emphasis on less invasive methods of fracture stabilization. Number 3, accurate reduction is the key. Now, accurate reduction is paramount for all intra-articular injuries, especially of weight-bearing joints. But that is easier said than done. For reduction accuracy, we must understand the fracture pattern, and this is possible by using the complete augmentarium of diagnostic modalities available. Now, we know that the majority of these fractures have 3 major fragments: the medial malleolus or the medial fragment, the anterolateral fragment or the Chaput's fragment, and the posterior malleolus or the Volkmann's fragment. Now, studies have shown that there is consistency in the fracture line configurations in a majority of C3 type injuries. This is termed as the bend sign or the triradiate sign. Keeping this in mind, we now know that in addition to specific fracture lines, there are specific zones of comminution that exist. And understanding of these patterns can help in better preoperative planning and execution of the surgery. Number 4, therefore, proper radiology is essential. Unless and until you have proper radiology, you cannot proceed with a good reduction and inadvertently will lead to a poor result. Remember that improper views will give you false information and guide you on the wrong path. Now, often it is said, is CT scan an absolute essential? Well, this is a study that was published in Clinical Orthopedics in 2006, and it established the importance of the CT scan. Pre-operative CT plans had to be changed in 64% cases by surgeons when CT scans were provided to them. Number 5, fracture classification and patient factors will dictate your treatment. Now, we're all aware of the AO classification, which divides these fractures into extra-articular, partially and completely articular ones, and then following subdivisions. But a more practical classification for understanding purposes will be dividing these injuries into rotational injuries, which are low injuries, often with a spiral configuration without much comminution. These are relatively easier to treat. And then there are the high velocity injuries or the axial loading injuries, in which, in addition to the marked displacement, are 3 impediments to a good result, which are the marked comminution, chondral impaction, and articular debris within the joint. Now, looking at this, the most important aspect is to evaluate the characteristic of the fibular fracture. This defines the mechanism and guides the treatment. The fibula can be fractured in a tension mode, in a compression mode, or may not be fractured at all. So number 6, most cases will need surgery. Now, when dealing with low energy injuries with insignificant soft tissue involvement, we can primarily reconstruct the fracture and mobilize early. But high velocity injuries are a different ball game altogether. Post-injury CT angiograms have revealed that blood flow and tissue oxygenation are greatly impaired. This remains so for a minimum of about 5 to 7 days. This gives us a rough idea when not to operate. Remember, early surgery is associated with more complications. So in high velocity injuries, stage treatment is advocated. It is based on the principle of distracting and stabilizing the joint while waiting for the soft tissues to recover completely. Ideally, you should also get your CT scan done after you have regained length and placed the limb on an external fixator. Now, the size of the fragments, the degree of comminution, and exact fracture lines may vary. But like said earlier, they have some consistency. And the interval between the medial and the anterolateral fragment is often the path to seeing inside the joint to help you get an accurate anatomical reduction. Thus, the position of this fracture line will be the main determinant of your best surgical approach. Also remember this part. The most prominent medial part of the tibia is termed as the medial shoulder. We will discuss this later. Now, so the principle that you should follow is the scan, and then thereafter plan your surgery. Another important aspect that is often dealt with is what is the correct time of surgery? Well, there's no specific time of correct surgery, but all studies have advocated different time periods of waiting. Important to remember, it should be based on the case to case, depending on the soft tissue damage, but do wait. Point number 7, surgical and implant choices. As stated earlier, fibular fracture anatomy will determine the implant placement and hence your incision choices. If you have a medial displacement, you naturally need to provide with a medial support to prevent a varus and therefore a medial buttress plate. On the other hand, if you have a lateral displacement, you need to provide a lateral support to prevent the valgus and therefore a lateral buttress. But often you are dealing with high velocity axial injuries in which there may be a talus impaction and chondral depressions also. These would require combined approaches, often with multiple implants being used. So now coming to the cut section. If your anterior fracture line exits medial to the medial shoulder, then an anteromedial approach is indicated. However, if your anterior fracture line exists lateral to the medial shoulder, then an anterolateral approach would be advisable. If you incidentally do not have cut section CT scans with you, remember, think of the valgus or the varus. Important to understand, for varus injuries, ideally a medial plate; for a valgus injury, a lateral plate. Also remember that nowadays there is more involvement of distal tibial fractures in motor vascular accidents, especially with the greater advent and usage of airbags and therefore anterolateral comminution, and hence the more usage of anterolateral plating. So in conclusion, your determining factors would be the fracture pattern, soft tissue involvement, and the stability that you have achieved. Now, this is a relatively easy C1 type of fracture, can be easily treated by a MIPO placed medial LCP. But when you're dealing with a more complex injury, then you have to have a greater understanding of the fracture. This is a C3 type of A3 type of fracture. Now, if you see, we fixed it with a medial plate and fixed the fibula with a TENS. But if you see in the postoperative X-ray, there's about 6 to 8 degrees of valgus malalignment that can be appreciated on the lateral view, and about 10 degrees of a posterior angulation. We accepted this, did not try to change or correct it, and a follow-up at 12 months shows that there's good union with good functional results and no progression of the malalignment has taken place. Another example of a C3 fracture. Now, the anterior fracture line here exists medial to the medial shoulder, and therefore, lateral to the medial shoulder. Therefore, through an anterolateral approach, we proceeded to achieve an anatomical reduction. After this, then we put interfragmentary screws from the medial to the lateral aspect and placed an anterolateral LCP, which then engaged the anterior to the posterior fragment, the screws. This is the post-operative picture and a follow-up at 6 months. I tend to enjoy the anterolateral plating also because it gives me greater purchase into smaller fragments, which are slightly more difficult to deal with medial plates. And also it avoids all the implant impingement, especially if you're dealing with a thinner patient. Here again, through an anterolateral LCP, the fixation is being done and the fibula is also being fixed with an LCP. Finally, certain fractures will also have involvement of the lateral as well as the medial malleolus. In this particular case, after open reduction of the articular fracture fragments and fixation with an anterolateral LCP, we buttress the medial component with a 1/3 semitubular plate. In conclusion, I would like to say that timing is the key to achieving success. Understand the anatomy of the fractures. Important to choose the correct approach. Accurate reduction essential for all intra-articular fragments. Always be very, very soft tissue friendly. Wait 1 day more than you think is the time that you need to wait. Thank you for your patient attention. Remember, like what Bruce Salter had said, incisions are less important than your decisions. Thank you.
Thank you, Dr. Jamal, for a nice presentation here. And the next topic is a very interesting by Dr. Unmesh Chakravarti. I invite him for the posterior malleolar fracture, when and how to fix. Dr. Unmesh, please share your skill. Thank you so much.
Good morning, seniors and friends. It's a great honor to be here today. I will be speaking on posterior malleolar fractures, when and how to fix. Before I begin, I would just like to put a question so that we can go through the progression. Does posterior tibial fragment have a prognostic value? Now, sorry for this. So as it has already been discussed, that if you look at the ankle, there is an osteoligamentous ring, which stabilizes the entire ankle mortise in the coronal plane. But there is also a ring in the axial plane, which gives it stability, and the stability is determined by the level of the fibular fracture, the status of the medial fragments, the syndesmosis, and overall ankle stability. So we have two rings, one in the coronal plane and one in the axial plane. So when we're talking about posterior malleolar fractures, this ring in the axial plane is what determines the stability. Now, if we look at the X-rays, as we had been conventionally taught, small fragments, it used to say, that fix the fibula and the posterior TF ligament would take care of the posterior fragment. If it's a 25 to 30% large posteromedial chunk, we again fix the medial and the lateral malleolus, check for stability, and we decide upon. And if it's a large fragment, then we used to primarily go in for the posterior malleolar fixation. Now I would like to take up a case. Here is a 7-day-old injury treated with an above knee cast, and it was reduced, and a back slab above knee cast was given. And a 1-month follow-up check X-ray showed this kind of a displacement. Now, if we see the CT, we can understand very well. It is just not the bony fragment. The entire subluxation has occurred because of the posterior lateral osteoligamentous complex, which is injured. And that is what is very important. We need to recognize, understand, and manage. Now, with better imaging, we now know that it's just not the lateral view. The size that we see in the lateral view is as important as what is the transverse width of this posterior malleolus, the height of these fragments, and if we reduce the talus from the CT and see the ankle mortise end on, the location of the fracture line, which will also be very, very important deciding upon the stability. So we have the Bartlett's classification, which is CT based. And if you see the type 1, which comprises of 8% of the fractures, it's basically an extra incisorial fragment with an intact fibular notch. The type 2, which is most common, is a posterolateral fragment extending into the fibular notch. The type 3, which has two chunks, the posterolateral and the posteromedial, which comprise 28%, and the type 4, which is a large posterolateral triangular fragment. And if you look at the CTs, you can appreciate that how they would look in 3D, and that's what it looks on a simple lateral X-ray. So what I would like to emphasize is CT is very, very important, and with easy access, we must get it. So again, coming back to this X-ray, so this is how they look very horrible on day one when they come to the OPD. And what is important is to immediately either give a hematoma block or a local block or a sedation and reduce it, get a back slab and get a CT scan. But a reduction like this does not ensure upon stability, and they tend to sublux like this. So a dynamic understanding of the stability factors like a pelvic ring, that is what is needed when we're dealing with these fractures. So if you look at this graph, the top line shows how the percentage of subluxation increases as we progress from type 1 to type 2 to type 3 to type 4 fracture. And that is because the transverse dimension, the height and the depth of the fragment becomes large. So a type 1 mostly can be managed conservatively. Type 4 almost always requires fixation. And type 2 and type 3 are those which have to be just on a case-to-case basis and usually would require fixation. Also, it's just not the size of the fragment, it's also a location of the fragment. A type 1 can be very small, but it can move around from medial to lateral side. Similarly, a type 3 can have varying sizes of the medial and the lateral fragment. Similarly, a type 4 can have varying sizes of fracture line and locations, as already has been discussed. Now, timing is the key. And as Dr. Jamal had really pointed out, the first 7 days are when the soft tissues are bad. That is because the circulation is very poor. So on day 1, it can look like this, but on day 5 or 6, it can look like this. So the soft tissues are paramount. They have to be understood, and accordingly, the timing has to be dealt with. When in doubt, and there is subluxation, it's a good idea to do a stage surgery. A fixator can be very helpful. It not only takes care of the soft tissues, but also helps in reduction, which can make your definitive fixation easier if you're going to delay the second stage surgery. Now, the posterior lateral approach is the workhorse incision for type 2 and type 4 fractures. It can also be used for type 3 fractures. It is always done in the prone position, and the incision is very simple between the tendoachilles and the fibular-lateral border. You just open the skin and you go between the TA and retract the peroneal muscles laterally, and there you can see the posterior malleolar fracture. Once you have done with it, you can just slide the peroneal muscles medially, and then you can fix the lateral malleolus posteriorly. And if you look at the windows, for type 1 fractures, it is not a good option. Basically, it visualizes the fibula well. You can palpate the medial fragment. For type 2, it is excellent as it's bang on. For type 3, yes, the lateral fragment is bang on the center, and you can always palpate, and you can slide the plate like a T plate or an L plate, which can take care of the medial fragment. And for type 4, again, it sits bang on the fracture fragment. Now, this is a case of a type 2 fracture in a 30-year-old active male, and that's how the CTs look. And you can see it's a small fragment, but it's a large in the transverse width as well as in the height. It can easily be fixed by the posterior lateral approach, and the posterior malleus can be stabilized with lag screws. And with that, you have to do the necessary fibular and the medial malleolar fixations. Once that is done, this is how it looks in the postoperative, and they heal well as long as the principles have been followed and the mobilization has been done timely. But a similar fracture in a 55-year-old female, where the bones are soft or there is comminution or the fragments are very small, after fixing the fibula, you might need to put an anti-glide plate. And once the anti-glide plate comes in, the fracture is reduced, and then you can do the definitive fixation and stabilize the rest of the medial malleolus, and that's how they can look. So the decision between the screw and the plate has to be taken on a case-to-case basis. Now, type 4 fractures, when there's a large single chunk, again, the posterolateral will give you an excellent view, bang on the fracture. That's the fracture. Once it is reduced and stabilized with lag screws, since it's a big chunk, it's better to put a large anti-glide plate. Normally we use the 3.5 or the 2.8 distal radial plates, reverse bend it so that it really buttresses the fracture well. And that's how it looks on the AP, and that's how the fixation looks. Now, the posterior medial approach, that's very common, we are used to it, is basically an extension of the medial incision that we give, and we go between the posterior neurovascular structure, the tibialis posterior tendon, the flexor distrium longus, and it's excellent for stabilization of the medial and the posterior medial fragments. A fracture like this, a simple X-ray will not give you a good idea where the fragments exactly lie. You need to get the CT to have an idea where the fragments are. And once you see them, then you can plan. And so we put an anti-glide plate for the medial malleolus, and from the very same incision, a posterior medial plate has come in for the flange, will take care of both the posterior fragments, and the fibular fixation has been done. That's how they look in post-op. Yes, what is important is a good anatomical reduction and a stable syndesmosis so that the function is well. Now, the most important thing to understand here is that the slightest step off is not accepted. A fracture like this, where you can see the soft tissues were bad, a fixator was foot, the fixator is still there, and with the fixator in situ, the entire definitive surgery was done, the fixator was removed, and probably he had a posterolateral corner instability with a posterolateral fragment with some chondral loss, and that's how it looked on 6 months, and you can see the lateral joint space going down 1 year and at 2 years. So it's very important to understand the ligaments, the entire complex, and the reduction has to be perfectly anatomical. To conclude, appreciate the osteoligamentous ring in the transverse plane. It's very important just not to go by a lateral view X-ray. You need the CTs because the transverse diameter, the width, the height of the fragments are very important. Soft tissues are vital and paramount. So the timing is of essence. You need to decide upon the posterolateral or the posteromedial incision depending upon the fracture geometry. Anatomical stabilization is very important, and the smallest step can lead to arthritis. Thank you.
Thank you, Dr. Nish, for a nice presentation on a good topic, and it is a very debatable sometimes whether which size to be fixed or not. The next speaker is Dr. Abhishek Kini from Mumbai. Topic is on the management of calcaneal fractures. So I invite Dr. Abhishek, please.
Yeah, thank you, sir. Thank you, UP Orthopedic Society for inviting me. Can I share my screen, sir?
Yeah, please.
I think, thank you. So, to be precise, on calcaneal management, I think we as foot and ankle surgeons can keep on talking and talking and talking, but I'll just give a brief outline of what to do and what not to do in calcaneal fractures. I'm from Bombay. And so when you see this fracture, the first thing that comes to us, maybe during my residency days, calcaneal fractures, we would always cast them, but nowadays we always go and plate them. So whether to conserve or what to fix, there is no always or there is no never. So there is a middle way where we need to, this is an intra-articular fracture which needs fixation, most of them. So going by calcaneum, it's a common fracture, 60% of all tarsal bones, 2% of all fractures. But 75% of these fractures are intra-articular and they need to be addressed appropriately, like how you would do any other articular fractures. So what not to do is always fix or never fix. So if you look at history of calcaneal fractures, the pendulum swings from conservative to operative, then again conservative, and then again. A lot of randomized controlled studies have shown that the results are good even in conservative, but we need to take them with a pinch of salt. So almost 25 years, almost 30 years now back, there was Paley said that there was lack of standardization in fracture classification, and failure to understand the fracture anatomy was slowing down the progress of calcaneal fracture management. This actually stands true even till today, where there is a lot of variations among our colleagues where what to do and how to do. And hence this talk, where in the following slides we would try to discuss what things to do. So this was a landmark paper where Rick Buckley said that in almost 400 patients, operative treatment, everything, conclusion was that there was results were equal in operative and non-operative group. But if you remove patients with workman compensation, operative groups did better. So there was a lot of corollaries, a lot of things where the finer prints had to be read carefully in such randomized controlled trials. So, and non-operative treatment involved increased risk of later on subtalar arthrodesis. So subsequently, independent systematic reviews have all said the same, that there has been unclear evidence about calcaneal fractures, but a lot of things, like if done properly in correct indications, patients did benefit out of it. So 3 fracture groups which needs to be considered for fracture are in fibular impingement, or where the heel is in valgus, where in future the tip of fibula gets embedded in the lateral wall, causes a lot of impingement signs and pains in the lateral side. In patients who have heel varus, where in patients end up untreated patient end up walking almost on the lateral wall of the lateral margin of the foot and end up in pain. And non-operative treatment involves risk of subtalar arthrodesis. So these 3 points we need to keep in mind. In assessment, all 3 factors influence whether to treat, when to treat, and how to treat. So for that, patient factors, if patient is diabetic, smoker, peripheral vascular disease, fracture factors like soft tissue status, which is very important. Look at the fracture anatomy for widening of heel, lateral impingement, dorsal tilt of talus. And equal important is surgeon factor, where there is an experience of the surgeon or the skill sets of the surgeon come into picture. So factors to consider are fracture pattern, patient related factors, soft tissue related signs, incision, and surgeon skills on decision making and technical expertise. So you need to take this with full caution, that severe wound problem or infection if happens, the patient will be worse off than if you had not done anything to the fracture, like primum non nocere. So you have to be sure that you do no harm when you can do no good to the patient. So fracture patterns to be avoided to be operated are where there are these 3 factors like fibular impingement, heel varus, or dorsal tilt of talus. So if you are planning to operate, they only ask for a CT because it's an interarticular displaced fracture. You need to consider patient factors. So fracture patterns, 1, if you see this is a fibular impingement. If you can see my arrow, this is the lateral wall blowout where the fibula is kind of getting embedded in the lateral wall. And this is a heel varus. So if you look at this in the X-ray on the axial view, the whole heel is in varus, and that's what are important factors, and that's how we go in and correct the heel varus by getting the heel corrected, neutral, and then fixing it with the sustentacular fragment. Severe heel varus, if I have to go through the X-rays, the previous slide, the previous case, this is how the heel is corrected, and then you neutralize with a plate for calcaneum fracture. So this is a dorsal tilt. So if you don't correct this, the patient will end up in having anterior impingement, and pain will be on the anterior side of the ankle. You need to correct this. So there's an Eastwood classification for depending on the lateral wall blowout, and they're divided into 3 groups. So this is what, if this is the fracture which kind of needs to be addressed, this would look like, this is where the lateral wall is blown out and there is a depression. You need to correct that and then fix it with a neutralization plate along with certain screws. So in type 1 and 2, how you go about it is you need to bring down the wall, elevate the fragment, hold it to the neutral, hold it with the subtalar joint of the talus, use that as a template and then fix it. In lateral wall, type 3, you need to elevate it, go trans fracture, go and reduce the sustentacular fragment and then bring it down. This is how it goes. And fractures to be avoided operating on would be comminuted intra-articular fractures, but the hindfoot shape is maintained where the heel is narrow and talus is not tilted. So these fractures are easy candidates for in situ arthrodesis in future if required. Coming to patient factors, you need to avoid smokers, non-compliant patients, men worse than women, and over 50 are worse than under 50, and compensation claim going on. So timing and soft tissue is very important. You have to avoid till we kind of all such blisters settle down. Wait for the wrinkle signs to come, let the bruising clearly demarcate, and incision. So incision has to be like, it is an extensile lateral approach. You need to make it slightly obtuse. This angle is where your subtalar joint is going to be. So you need to make it liberal, where if you draw this, extend this subtalar joint angle distally and proximally, you need to extend it till that level. So your L limbs have to go right up to this point and come sometimes up to the 5th metatarsal base. So this is what we meant. It sometimes extends almost 5 centimeters above your calcaneum, and this is how it goes about. So here is the sural nerve you need to be careful about. This is the incision, just as a recap of what we just said over there. Coming to surgeon skills and decision making and technical things, extra-articular fractures also need to be fixed, especially the avulsion fractures, which are like one of the very few foot and ankle emergencies which you cannot neglect, otherwise it causes skin necrosis and ends up in a flap. So open fractures of calcaneum, current concepts are that it depends on the extensive debridement and the surgeon's assessment, risk of infection. Loss of heel pad, get the plastic opinion on day 1 because they cannot be reconstructed. And sometimes below knee amputation is better than a painful stump on which the patient cannot bear weight on. So you need to discuss all of these factors with our patients when you see an open calcaneum fracture. So issues in intra-articular fractures are it causes long-term pain and loss of functional ability, loss of soft tissue paramount to decision making. Plain X-rays alone are not adequate for workup or surgery. Extensile lateral approach gives acceptable results in selected patients. MIS, minimally invasive surgery, is technically demanding and has a long learning curve. Subtalar arthritis is the commonest complication, but it can be easily salvaged when in situ fusion is possible. What are the consequences of calcaneal fractures? Arthritis, subtalar, and then fusion. Heel widening causes lateral impingement. Loss of calcaneal height can cause anterior impingement. Weaker gastroc causes higher tendoachilles insertional lever arm, and decreased dorsiflexion angle, anterior impingement due to dorsiflexion of talus. So in my personal opinion, if I have to deal with my own consequences, then our decision should be to make future subtalar joint fusions easier. In some fracture patterns where subtalar arthritis is inevitable, so aim of surgery is to prepare the hindfoot shape for future subtalar fusions, and rarely primary subtalar arthrodesis is an option, but it's a technically demanding challenge. So my opinion indications are, as I said, in the right patient, in the right time, by the right surgeon, or subfibular impingement or severe valgus or severe heel varus where the heel alignment is affected, fractures where dorsally tilted talus so that we avoid anterior impingement. In avulsion fractures of tendoachilles and in open fractures, I debride and then I decide. So subtalar arthrodesis, this is how it goes. In situ is easy. And sometimes you have to reconstruct with a posterior bone block for distraction to get the talar inclination down. For lateral impingement, you need to do a lateral exosectomy at the level of the fibular groove. And that's how the whole calcaneal is taken care of. Thank you very much, sir.
Thank you, Dr. Abhishek. for a nice presentation. And the session is open for the discussion. So there is a question for Dr. Unmesh. When you fix the posterior malleolus and fibula in a prone position, so for when you go for the medial malleolus, can you change the position or you do in the same prone position? Is there any tips or tricks or anything else?
I think we question ourselves every day once we have done the posterolateral fixation that should we flip the patient. But my take on this is that usually the medial fragments are small fragments and they can easily be managed by minimal fixation. What I mean to say is either a tension band wire or cannulated screws. So a simple trick without flipping off the patient is you flex the knee. Basically, the problem is that we are not oriented to the foot pointing down towards the floor. We are oriented to foot pointing towards the ceiling. Now, if the patient is prone and you flex the knee, the foot again starts pointing towards the ceiling and not towards the floor. And you can start, you go towards the head side and you start operating from the head side towards the distal end, and the orientation is corrected. It's very easy to put cannulated screws. I don't use cannulated screws. I'm a fan of doing a tension band wire. It takes some more time, but it can easily be done. But yes, if you have to do a more extensive fixation where there's comminution or you need to do a bone graft or extend medially, then it's always better to close the wound, flip the patient, and do it in a supine position.
Okay. So how you check the stability after fixing all that? What are the ways to check your ankle stability after fixing all the three malleolus?
So usually, as I said, I do not change the position, because if you're changing the position, you've done a fixation, close and change the position, that's the problem, because now you have to go in again and change it. So you do it in the same position once you have, if you think that the posterior malleus is very small and difficult to fix, you can fix the fibula, provided you have been able to reduce it kind of. Otherwise, sometimes fixing the fibula initially can be troublesome. Otherwise, you just reduce the posterior malleus. It's easily done by a calcaneal pin, pull it down, traction it, reduce it, put some K-wires, fix it with a lag screw or with a buttress plate, fix the posterior fibula. And that is where you get your C-arm in both AP and lateral plane, move the ankle, the entire tibio-talar joint in the plantar flexion, dorsiflexion range, and check it is stable or not, whether it is not displacing. Whenever in doubt, put a buttress plate and an anti-glide plate. Once that is done, then what is important is doing the middle malleolar fixation, which will again take care of it. And then again, the entire stability has to be checked. So it is always wise not to do one fixation, close it, and go towards the middle side, because just in case you need to revise, then you are stuck up and in a loop.
Okay. Is any other questions for any other speaker? I think no other.
Can I ask? Can I ask a question, please? Yeah. Please. Can I ask a question to Jamal, please?
Yeah.
Jamal, have you had problems of non-union in the early days when you might have been fixing the fibula first and then coming back and addressing the tibia later?
Can you repeat that?
Have you ever had trouble with non-union of the tibia in pilon fractures if in the initial years when you were doing this, you had fixed the fibula first and then come back later to fix the tibia?
Well, I still continue to fix the fibula first and continue to fix the tibia later. I have had non-union of the tibia, but never actually analyzed it on the basis of it being a non-union because I had fixed the fibula first.
So my theory on this, and I might be wrong totally, I've had 3 of them in all these years, and in each one of them, the fibula was fixed very accurately. Because the metaphyseal bone at that end of the tibia is pretty soft and the impact of the energy is so hard that there's always a subtle gap that is left behind. And every time I have come back and fixed the tibia, I've always found that it never has a good apposition of the 2 fracture fragments. So what I do now is I don't fix the fibula at all. I put an X-fix and just leave it like that. Then I come back and I make sure that I have the tibia fixed nicely, then go back. And if I have to shorten the fibula a little bit, I shorten it.
I don't know about Unmesh, but we tend to always fix the fibula if it is in the distal 5 centimeters, maybe from 5 centimeters to about 10 centimeters. I would actually want to stabilize it. If it's a little higher up, I still want to stabilize it with a K-wire or a titanium elastic nail. Want to still stabilize the fibula.
No, that's fine. That's fine, because I just had 3 patients like that, and I've been thinking of why it might have happened. So I'm not fixing the fibula at all initially now.
I think that's very pertinent, because fibula can sometimes be very helpful, but sometimes it can be very troubling because of the metaphysical combination, as you said, sometimes because of rotations, which you're not able to judge right there because we are seeing 2D planes. So I think it has to be taken on case to case basis and have the flexibility, maybe just fix it with 1 or 2 screws, and if necessary, just remove the screws and do a readjustment. So that's why changing the position of the patient between the surgery is not a good idea. Sometimes you can really get stuck up.
Thank you, Arvind.
No, thank you very much, Jamal.
Thanks for having you.
Can I make a comment for that calcaneal fracture?
Sure.
I think the MIS surgery is the way to go with most calcaneal fractures now. I used to do the extensile approach, and I had problem with wounds like everybody else. And I must say, since I have moved to this MIS or the sinus tarsi approach, my wound issues have become a lot less. And most people, I think, have realized that if they can get good at it, it's the way to deal with the calcaneal fractures. The extensile lateral, I think, is slowly becoming not as common as it used to be. And it's not very difficult. If I can learn it, I think anybody can. It's not difficult, just a few cases and you get pretty good at it.
Probably, you're absolutely correct, but probably for someone who's starting off with a calcaneal fixation, it would be wiser to go in for an open reduction over a period of time, get the feel of the fracture, the feel of the anatomy, and then try to go in for MIS.
Correct. I agree totally.
Abhishek?
Yeah, my take on it is, I think, especially as Dr. Jamal sir said that for MIS, I think once you're committed to it, you cannot turn it around and put an extensor lateral. So you are doomed. So unless you are sure that you are going to do that way, and you are sure that you're not going to cause harm, because not like maybe a Sanders 2, I would say yes, easy. 3 is a challenge. 4 is a bigger challenge. So, and once if I've committed to a sinus tarsi approach, if I put my incision there, and if I'm not getting my reduction, I cannot do anything. I have to leave it in situ and come out. That is as good as causing more harm. So I think I agree. I have a lot of patients, like I do sinus tarsi now, maybe 50-50, but if you ask me, like I'll do an extensor lateral, maybe much more easier at a spinal level, I would say. But sinus tarsi, I will plan, because I have to be sure that I'm going to get all my reduction perfectly. Sometimes you extend it behind, now there are retractors, now there are elevators, you can do a lot of things. Arthrex has an excellent plate to fix it also, which is now available in our country. But otherwise, I think implants are a problem. Reduction is a big problem. The other challenge with that is there is no bailout in that. So over here, like if you have to ask me, vis service and extensor lateral versus sinus tarsi, the complications that happen because of extensor lateral, please correct me if I'm wrong, I'm like a junior, but my statement is that it all depends on your hands at the time of surgery. If you manage that skin flap well, like if you elevate it full thickness, take your 5 minutes over there to elevate it, I don't think it is a problem. I don't think it's a problem. Like now what I'm like now, 9-10 years into foot and ankle practice, like this February, initially I had edge problems, but if you stick to it, put an obtuse angle, make an liberal incision, elevated properly, you can manage type 1, type 2, type 3, type 4. Anything you put under the talus fractures, extensor lateral is one answer to it. Sinus tarsi, yes, wound complications have been highlighted. But again, I think that's all my patients that kind of gives me a wound complication, or my impatience that gives me a wound complication. Otherwise, yes, sinus tarsi is interesting. So I'm not against sinus tarsi, but as Jamal sir said, that it has a learning curve, and I have seen eminent surgeons sinus tarsi approaches which are not reduced, and it has happened in my cases also, and I regret them. But in my last at least 7 years, I have not regretted putting an extensor lateral approach. I can mix and match anything.
Arvind, every surgeon tends to have some surgery that they're really impressed by. I mean, I find a lot of surgeons being impressed by fancy joint replacements, pelvic acetabular reconstruction. There's one surgery that always tends to impress me when surgeons show putting in joysticks and manipulating bones and all, because that's one thing I can never do. Whenever I put in a joystick, the whole thing moves and the bone doesn't move. I always just admire people who can do that, because I actually doubt they can do that, but they do present that.
No, I agree, Jamal. But no, I get his point. He's quite right that if he takes his time doing that approach and does it meticulously, there is very little reason that he'll get into trouble. And I totally agree. I've done both. You can do a lot more through the extensor lateral approach. With the sinus tarsi, you have to be pretty confident you can deal with those fractures to go and attempt them. But no, I get his point. I get his point totally.
And
thank you, Arvind. Thank you, Abhishek.
Thank you, sir.
I think we'll just close this. Santosh Boss.
Thank you very much. Thank you very much again.
The impatient arthroplasty surgeons have arrived.
All right.
Next session is on the.
Then the foot and ankle have to go out, I guess.
So session is hand over to Dr. Abhinav. Dr. Abhinav.
Thank you, Dr. Santosh. Thank you so much. So again, I would like to welcome you all to this next session. It was a very nice session. The next session is even more interesting. We have got a galaxy of faculty here. We have got panelists like Dr. Kapil Gulshrestha, Dr. Sandeep Kumar, and Dr. Arun Gupta. And moderating the session will be myself, Dr. Abhinav Agarwal, and Dr. R.P. Singh. So without wasting much time, moving on to the first talk. It is by Dr. Raj Kumar Natesan, and he'll be talking about the implant in revision THR, which and why. Dr. Raj Kumar, are you there, Dr. Natesan?
Yep, I'm here. Can you hear me?
So, hi. Yes, we can hear you loud and clear. Can you share a screen, please?
Definitely.
Okay, over to you.
Yeah. Okay. Good morning to all. I would like to thank Dr. Jamal for inviting me and requesting me to talk on this topic. I really appreciate your invitation, sir. Straight away, without wasting time, let me go into the topic. The topic, I just made it little revise the topic heading, like basics of hip replacement, because I just wanted to cover the basics, which will be very, very useful when we talk about the implants in a revision hip arthroplasty. So revision hip replacement, why does this happen at all? Why we need to do a revision hip replacement? So that is a question which every young surgeon would like to ask by himself. Hips fail due to aseptic loosening, instability, periprosthetic fractures, infection, and pain. So because of all these problems, then we need to do a revision hip replacement surgery. In India nowadays, for that matter, all across the globe, the number of primary hip replacements are going up and up. So eventually, we should be very much skilled enough to do a revision hip replacement to tackle these most common 5 problems. So in this, aseptic loosening is the most common. And if you look at the ISHK registry, where in India, it is 68.9% of aseptic loosening is the predominant cause. And next comes the dislocation and then the infection. So if you look at the journals, literature, the revision in young patients also are happening. What are the causes of revision in young patients undergoing a THR? It is mainly the acetabulum and femoral component loosening. That is the aseptic loosening due to polyethylene wear, which is one of the most common cause of revision in young patients. Whereas instability and infection is more common in older patients. So what are the problems we encounter? Unexplained pain, aseptic loosening, instability, infection, and fracture. These are the situations for which we do a hip replacement, revision hip replacement. So when planning a revision total hip replacement, you should not hesitate to do all these investigations. It might look very, very basic. It might sound basic, but it is very important. All the routine investigations, rule out the infection by the biochemical markers. Screening has to be done. Nowadays, more of HbSAg and HCV are becoming positives. Check the diabetic status. Don't hesitate to control the diabetes before venturing into a revision hip replacement. Stop smoking and alcohol at least 2-3 months before the surgery. Vitamin D level and osteoporosis has to be checked and has to be treated. Cardiac status and anticoagulants is very, very important to know the exact status and discuss the risk factor involved in these cases because the long duration of the procedure. So make it as a routine for all cases. So coming to aseptic loosening. So when this kind of x-rays we encounter very commonly, and the biggest question we see is we ask ourselves is whether we need to aspirate or not. The answer is no. Why? If we need to aspirate, it has to be done only if strong clinical history of infection and raised to CRP. If this is there, then you aspirate. Otherwise, you don't need to. And sometimes a radiograph demonstrating a focal lysis, aggressive non-focal lysis, and some sort of periosteal reaction, yes, then you can aspirate. Otherwise, the answer is no. And this is what has been done. A hemispherical jumbo cup has been used, ETO to remove the implant, femoral component, and then a distal loading stem. These words will be very commonly used in this talk now because this distal loading stem, hemispherical cup, and an ETO. This is the Bible of a revision hip arthroplasty. So preoperative planning, appropriate x-rays and views. Yes, definitely it is a must. CT scans, yes, sometimes in a complex revision scenario, you will need a CT scan to assess the bone loss or a non-union sort of, in a trochanteric fractures, non-unions, you need to know. So talk to the implant company, very, very important. Always talk to them prior, before itself, show them the x-ray, talk to them, get the appropriate sizes. Don't hesitate to order for all the sizes because that will bail out in majority of the cases. Discuss with your anesthesia team. Talk to them about the blood loss, the duration of the procedure, anticoagulant prophylaxis. OT staff should be briefed in advance to prepare yourself for the instruments like the screwdrivers, SS wires, C-arms, everything. So this is like a teamwork. A primary hip replacement is a different ball game, but in a revision scenario, you need to plan so many things. Again, one more, this is a different aseptic loosening. You have to classify the bone loss. Paprosky classification is very good in that. Take a proper x-ray, assess the medial wall and the anterior column. That is the teardrop, Kohler's line, superior migration, and ischia slices. All these four is like a dictum. Use this, you will not need a CT scan at all. And the oblique views is a very, very important. It will give you the exact posterior column integrity and the lysis level. 3D reconstruction, CT with 3D reconstruction, yes, only for a posterior column integrity. Otherwise, you don't need a CT at all, only a plain X-ray. So what is the principles? You need to know whether enough bone is there to support the standard component, whether enough host bone is available. Do the columns need a reconstruction? Do I need a special cup and do I need an allograft? These questions you have to be prepared, but still perioperative findings might differ. So you have to be prepared. That is where your preoperative planning helps you. So what is again the principle? Rigid fixation, center of rotation at the correct place, restore the bone stock and avoid component impingement. Very, very important. Get your center of rotation even in a revision. Don't compromise on that. Always try to get your center of rotation correct. Majority of the Paprosky type 2 defects can be tackled with a hemispherical or a jumbo cup, cancellous screw and a cancellous bone graft, allograft or an autograft, whatever is available. Most of the time you can get away with this hemispherical highly porous cups. So what helps? What is advantage? It permits ingrowth, remodeling at the metal bone interface, and also it prepares the bud for the future procedure. So graft restores the bone medially. Again, femoral side Peprosky classification helps you. Example here, aseptic loosening. Always remember, whenever there is a well-fixed implant, don't hesitate to do a ETO. The level of STO has to be marked before itself, templated, appropriate implants and sizes has to be used. Again, this is a case which was done with a jumbo hemispherical cup and a distal loading stem. So here the principle again is center of rotation achieved, cup placement has to be proper, offset achieved, ETO performed, and a distal loading stem. Very, very important. Prevention of intraoperative fractures. Don't hesitate to use an intraoperative C-arm. Whenever there is a doubt, stop there and use a C-arm. In revision cases, don't hesitate. Cement removal instruments. These are the instruments very, very important. The grabbers, osteotomes, and then drill bits, various sizes of long drill bits particularly. All this has to be there. Don't hesitate to do a ETO. Well-fixed implant like that needs ETO to remove the cement. Otherwise, you will be struggling. So prophylactic wiring distally has to be done with SSYs, which I always prefer. Do use saw bit, small saws and long grabbers for distal reamers. This distal reamers, when you are using, use a C-arm. Exactly see where the reamers go. It should be intramedullary, and then you do a prophylactic wiring. And again here, a jumbo cup and a distal loading stem, wiring done prophylactically and the ETO portion. So this is the workhorse, and this is the go-to stem in a revision. Uncemented distal loading stem is must for a revision, no doubt about it. So the cemented options are coming down, and the uncemented, these titanium stems give excellent results, and the outcome is far, far better than the cemented stem. Cobalt chrome stems, nowadays it is not advisable for various revisions. Breakage is common, thigh pain is common. So titanium distal loading stems, whether a modular or a monoblock, it is up to your choice based on the patient's need. So infection, again, 59-year-old male, very, very common in our Indian scenario. Infected bipolar, again here, two-stage revision is a must. Go ahead, no role for aspiration. If it is very obvious infection, straight away two-stage revision, remove the implant, do a debridement, cement spacer. Again, second stage revision, distal loading stem with a simple hemispherical uncemented cup. So no need for repeat aspiration before revision, because if your blood parameters should guide you that the infection is controlled. Post-traumatic situations, these kind of long-standing loose implants inside, very, very difficult to remove. See the debris it has created, and it took so long just to remove the implants. So if prolonged surgery with doubt in infection, don't proceed with the revision straight away. Put a cement spacer, take multiple cultures, and again, after 6 weeks, you can go ahead and do a distal loading stem like that revision. So here, the most important thing is the bone loss is tackled by a T-Mars revision shell, T-Mars tantalum augment, cemented cup. And then for the femoral side, distal loading stem, SS wires, and obviously allografts is a must on the acetabular side and the ETO side. So these things has to be kept and be prepared. For that, you need a preoperative templating, preoperative discussion, and a teamwork, discuss with the company people. So post-traumatic situation, again, very, very common in our place. So here, majority of the time, a single stage THR can be done. You will need all types of sizes of screwdrivers. So various companies are there with nails, PFNs, AFNs, and all those things. So you need a hexagonal, 4.5, 3.5. We don't know what is there inside. With X-ray, it is very difficult. So be prepared with all sizes of screwdrivers and get the various screwdriver heads so that you will be able to remove the implants and then proceed with the THR. So here, this again, a distal loading, short distal loading stem is a must, because the trochanteric anatomy is altered. We don't know the quality of the trochanter, so it will be soft osteoporotic. So use a short distal loading stem and a hemispherical cup. If the plate is not coming in your way, you need not remove it. Otherwise, you have to remove it. Again, one more patient, 60-year-old male, post-traumatic situation. The key point here is, here we need a CT scan, because you see a bone mass in the superior aspect here. So you need to know what is happening. So the CT scan revealed that there is a big heterotrophic ossification. So this ossification was very, very difficult to remove. The screws, plates, everything was embedded inside the ossification mass. So I had to remove the entire ossification mass to reach the screws and plates. This was a defect. So heterotrophic ossification was removed, posterior bone defect in the acetabular wall, migration of the hip center, and the greater trochanter screw. All these has to be tackled. So for that, you need the appropriate implants and the instruments to remove the screw. Here, the greater trochanter screws head were broken already inside. The threads were broken. So I had to use a screw removal, broken screw removal set. AWO has got a very good broken screw removal set, which I had to use it and then removed the screws, plates, everything, and the ossification mass. Then here I used a hemispherical cup and a augment to fill the defect. So this is the TM augment which was used, and then a continuum cup and a corail stem. Here you just need a regular uncemented stem for the femoral side, because the majority of the problem was on the acetabular side. One more example, 57-year-old female. Whenever there is a doubt in these kind of fractures, better to take a CT scan to make sure there is a non-union, and also head lysis is there. Revision fixation is a very complex procedure here, and high chances of again one more non-union. So here a distal loading stem. The key point here is your distal loading stem has to cross the screw site, screw track. So you have to use a longer distal loading stem here, and hemispherical cup. Regular hemispherical highly porous cup is an advantageous in osteoporotic fractures. So dual mobility, again, it is very, very advantageous in a revision scenario, but it should not be considered or compensated for a poor surgical technique or a technical error. So one more, here a patient with multiple surgeries done elsewhere came with this cement spacer in situ. When you opened here, you can see there is no lateral bone at all. If the cement spacer was very much exposed here, so the abductors were compromised. So here I used a distal loading stem and a dual mobility cup, and this is the post-operative X-ray. So here I used a MDM dual mobility and a modular MRP Titan stem. Here the modular stem gives a big advantage because of there is no abductors, there is no soft tissue tensioning. So you have to build up for that offset. So to build it up, your modular system helps because of the various sizes you get in the proximal. You get a good distal fixation initially, and then proximally you can build it up according to the offsets needed. There are various sizes. So here the modular system helps a lot more than when compared to a monoblock system. So the key again here is cup placement, soft tissue tension, and the offset. So dual mobility will work only, it will only lower the risk of dislocation and it will not prevent. So you have to be very, very careful in that. One more case, again, abductors compromised, revision scenario, distal loading stem, modular system with a dual mobility cup. So the key point here is in the modular dual mobility cup is again the risk of serial metal level elevation because of the modularity, multiple modularity. So you have to be very careful. But having said that, majority of the times you will not need a dual mobility even in a revision if you try to achieve the offset and the center of rotation. That is the point here. Again, cemented bipolars, loosened or broken, don't hesitate to do a ETO in these kind of situations. Immediately, straight away, do an ETO to remove the broken implant and do a distal loading stem. So ETO, implant removal, and distal loading stem. Uncemented, again, uncemented heavy, the same thing. Implant removal, distal loading. Here, since it is an uncemented, the broken implant you can give a try that you can remove it with the grabber. So here ETO was not performed. Again, a simple uncemented distal loading stem with a regular hemispherical cup. Loose varus collapsed implant always eats away the bone proximally. So there is a varus remodeling in the proximal portion. So better to do a ETO and a distal loading stem here. Instability, last few minutes. Instability, again, very, very common, and revision is very common due to instability. This is a case which was revised many years back on the acetabular side. The femoral side was very much intact, but patient came to me again 15 years from the index surgery and 7 years after the acetabular revision with severe pain. So what was the problem here? You can see the instability. Instability is the problem. The offset is loose. So here the offset is the problem. So I had to do a removal of the implant of the femoral side, remove it with the ETO, and then remove the process. For that, you need all this kind of small blades and saws. Light source, very important to remove the distal cement plugs and cement pieces. Explant system, always keep it ready keep it as a backup to remove the cup if the cup is either loose, partially loose, or if the infection is there, then you have to remove it. So always have the explant system. So in this scenario, in this case, I removed the femoral side with the ETO, and then after removal of the stem implantation, after removal of the stem, used a distal loading stem, achieved the offset. So here I didn't revise the cup, only the stem was revised, the offset was achieved, no dual mobility was used, and then patient had the abductors were sutured to the stem and had an excellent outcome. So the cup was retained, ETO was used to remove the stem, femoral offset achieved by distal loading, modular stem, abductors anchored. So again, the last one, periprosthetic fracture, B1 type fractures can be plated. B1 periprosthetic fractures can be plated and you can get good results. But the problem here is the B2. So these kind of patients, periprosthetic fractures, B2 shattered, but here the surgeon did not revise it. He has only plated it. That's why it failed in 6 months, 8 months time. So why this failed? Because B1 was considered, see, B2 was considered as B1 and fixed. It should not be fixed, it should be revised. So the B2 fractures has to be revised with the distal loading stem. So B2 always has to be revised with a THR, not fixed. One more 87-year-old female. Again, in this case, 17 years post THR, you can see that acetabular cup, cemented cup is still very well fixed. Only the problem with the periprosthetic fracture, shattered B2. So here I revised only the femoral side, cup was retained. So patient is doing well. So here the good fixation is by the distal loading stem, getting your offset and abductor tension correct. So implant choice and patient factors are very, very important. If the patient is osteoporotic, we have to be very careful, like in rheumatoid and elderly. Small deformed acetabulum and femur, plan and order the appropriate implant sizes. Sometimes you need to do an cemented acetabulum on in a small osteoporotic femur. Preoperative planning and workup is a must. So in revision, keep it in mind, center of rotation, offset, ETO, distal loading titanium stems, 2-stage revision if infection. So have all the necessary armamentarium to do a good revision total hip replacement. The key point here is adhere to the basic principles. Thank you.
Thank you, Dr. Rajkumar. It was a nice presentation. Without wasting much time, I'd like to invite our next speaker, Dr. A.S. Prasad, who will be talking about achieving a stable hip in the THR. Dr. Prasad, are you there?
Hi. Yeah. Hi.
Hello, welcome, sir. Please
Thank
start
you.
sharing your slides.
Yeah, just I'll do that. Okay. Good morning, friends, and what a welcome change, I'll say. And troubled times, but thanks UPOA for organizing this meet, and I can say it was very crisp. I have been listening to all the talks, very, very good talks, all of them. So I'll be speaking about achieving a stable hip in a complex primary situation. But you see, the goals remain same. We need a biomechanically sound, stable hip with a perfect balancing. So I'll get. And restoration of the normal center of rotation of femoral head. So nothing will change as far as the concepts is there, which Dr. Rajkumar just talked about. So apart from the arthritis of the joint surface, there is structural and pathological changes in the acetabulum and the proximal femur. So this is a case where we call it a complex primary. So, and the examples can be, the biggest example is definitely dysplasia hip, we call DDH, the protrusio, maybe because of rheumatoid or trauma. The ankylosed hips, ankylosing spondylitis is very common, and I think everyone is doing it. So it may be somewhat different than the absolutely a complex hip. And there are so many situation where it is associated with the fracture of the acetabulum and also the proximal femur. First thing first, and again, the age-old saying, failing to plan is planning to fail. And a complex primary is definitely more demanding than a normal primary totally. So a thorough clinical examination, again, it holds true for all the cases we do, but we must appreciate the range of movement, what are the restrictions, any fixed deformities and contractures, what is the muscle power? If there's something less, why it is there? Scars, if any, that will give you some clue about a old history of infection which might have led to all DDH findings. The person can be having an infection in the childhood, which has led to all the changes now. Shortening true and apparent, so you can always look at that. Radiological imaging is must in different angles, whatever you deem fit, and CT when you want some additional information, it can be definitely done. So don't shy away from getting a CT scan, especially 3D reconstruction, whenever we think it will give us some pertinent information. What we have to appreciate, anteversion of the neck and the length, neck shaft angle, valgus, varus, the medullary canal diameter, and the shortening. These are the things which we look into the proximal femur. And then coming to the acetabulum, we must appreciate the size of the acetabulum, the shape of the acetabulum, the placement, whether it's a low or it has migrated very much up, the depth and the pillars and the anteversion. So these are the things which will give us some idea what we are going to tackle and what can be the troubles during surgery. There's one case I'll just show and how I tackled it. There's a dysplasia. We can see the person has been walking with a limp since ages. And we can appreciate the acetabulum has migrated proximally. The true acetabulum is distal. The femur looks rotated and shortened definitely. Even if you look at the obturator foramen, so it looks like the pelvis is also tilted. Look at the iliac crest, which is deformed. So these are the information about the bony changes we can appreciate. The other things will come on clinical examination, whether the person has got a flexion, adduction, contracture or not. That's why I said CT scan is important. It will again give you a lot of information about the medullary canal and also the anteversion, the head, neck axis. And similarly, we'll look at the posterior side, we can appreciate the pillars and how the head is anteverted, how acetabulum, whether we have got sufficient bone to go in or we will need some support. And based on this, we will start thinking of what implant we are going to use. And we have got a very good implant selection there, but appreciate and find out what is available in our place. Templating gives a lot of information. I know what we template, what we think it will be there. So many things do change. It does changes during surgery, but still templating gives a lot of information. So please practice it, especially in a complex primary. We must be prepared with small cups because we do not know what is the size of the cup. We'll find out. Distal fixation stem, as Dr. Rajkumar said, they are the workhorse of all the revisions and also difficult primary. Because there are many times we need a subtrochanteric shortening, a derotation osteotomy. So which is just to compensate and get a good balanced hip, especially in cases of dysplasia. Cemented stems, narrow cemented stems can be a stem which will take you out of the bind, and cage also sometimes you may require. So just there's no harm if we keep it as a backup device, and definitely be prepared with the bone graft fixation if you want to deepen the acetabulum cup. Apart from that, I always advise that keep all your trauma armamentarium with you, all the plates, cables and wires with you, because you do not know what will happen during the surgery, because this is not a routine 20-minute job. So keep over prepare. Remember bailout buddies talk. What we have discussed, when जब हम फंस गए तो कैसे निकले. So these are the very important tips which we acquire over the years. went out in 90s for my fellowships, I was all looking out how they get out of the trouble. So that is very important. Try to talk with your colleagues, friends. Innovations are most welcome, but be conservative. Don't try to be very radical surgeon, especially because there's no comebacks. Check instrumentation a day prior to yourself. If you have got a very good team, it's okay, but otherwise, it's always prudent to get a check done. Approaches can be many. You can choose whatever you want. Remember, just for a case of difficult hip, don't try to change your approach. My approach is definitely a posterolateral with a posterior dislocation, but I have been doing the anterior dislocation also. And over the years, after initial 5 or 6 years, I settled down for this approach, which I practice. And you can see the simple rotators have been exposed. I can simply release it and expose the hip. For significant adduction flexion contracture, it can be released before starting this surgery through a small medial approach, the canotomy, or we can sometimes, if not much, we can tackle it during the surgery also from the same approach by rotating the femur. First thing is releases around proximal femur and neck resection. What I practice, first I do a proper release and remove the rotators, try to rotate the femur, find out if it is possible to see the level of the neck, and I try to remove resection of the neck closest to the LT so that most of the neck, if it is there, has been removed. And it is very difficult also. You cannot go proximal to the head in most of the cases of dysplasia also. Definitely rotators and piriformis are removed, the cut, tagged. Gluteus maximus tendon, in this case, it is prudent to cut it, tag it so that you can stitch it back. It really releases your proximal femur and you can mobilize it. Anti-band, if contracted, you'll have to give definite small incision so that it releases and makes the proximal femur more mobile. Go around proximal femur. That means when start rotating, go stepwise and remove it from the anterior side, the soft tissue contracture from the anterior side of the femur also in this approach. Mobilize it away from the fibrotic acetabulum. There's so much of fibrosis all around. Identify sciatic nerve in this case. Definitely you know where it is so that during surgery you know what you have to protect. So proximal femur must be mobilized before you start looking at the acetabulum. So mobilize it well, take 10 minutes or 5 minutes extra and do it. Dysplasia on the acetabular side, the bottom line is we have to try to restore center of rotation, and we can do a little medialation, and if necessary, we can go a little center of rotation, little high up also, which is known as a high hip center. Sometimes we have to accept it, but sometimes. A medial wall fracture technique is very important technique to achieve the depth of the acetabulum. I always keep my image intensifier in the operation theater for difficult cases of hip because it is a very good tool to identify where we are going. Because X-rays are good, but when you are opened it in the soft tissue, you may be missing where the true acetabulum is. So to identify the true acetabulum, I always take the help of this. To identify the femur axis or the intramedullary remors, I definitely take the help of Siam in this case. Another case like this, a pseudo-orthosis of the neck of the femur, the head is fused. We can open the neck fracture from there, osteotomize, but what about this? We cannot, it will be very dangerous to just ream over this. So make holes, find out, keep a drill bit, see under the Siam, find the real axis, then reamers, so that once you're sure what your axis is under Siam, then only start reaming fully. And reaming has to be very, very conservative in these cases. Go slowly, ream progressively, inferior part of the canal, because you see the actual acetabulum has migrated or sloped upwards. So you have to preserve that superior wall, go inferiorly first, and slowly, progressively try to find out the true acetabular cavity. And that's why, and keep on examining both the pillars, the anterior and posterior. You may not over ream sometimes. So have to be very conservative, go progressively, and be prepared to use a smaller acetabulum. If necessary, we can always use a bone graft superiorly in the defect so that we can contain the acetabulum there. And we must remember, we do not require all side coverage. Even 70-degree of coverage of the acetabulum cup is sufficient to get a stable fixation. But this, if need arises, we can use a part of the head and do a good acetabulum cup by deepening the cup, the socket at the appropriate place. So at the superior defect, we have applied a graft of the head. The medial wall fracture technique is again very good. What I do, I just you cannot take away the bone from the absolutely end of the breaming. Keep a small sliver of the coverage at the bottom of the sternum, and when you impact with a straws, it slips a little, becomes soft, and because the soft tissue coverage at the bottom is also there, and it gives a better hold and makes the cavity little around 4 millimeter up to 4 millimeter more deeper, and that's enough to get a proper fix at the rim of the sternum. So this is a very good technique, like I showed in the X-ray, and it gives a lot of satisfaction. I know it looks bad, but over the years, a little bone develops at the bottom or the floor of the sternum also. So once there, again, I don't shy away from checking my trials, and if I'm happy, the orientation, then I'll go and fix it up. So the concept of getting a 35 to 50 degree of inclination and anteversion, which is normal, is same. So once I have fixed the acetabulum, now I'll go to the femur side and try to adjust my femoral component to this acetabulum, which I have fixed first. In cases of difficult primary, I think this should be the first thing instead of going straight away for the femur. But again, this is my take, and it can vary. Everyone is good, and everyone can have his own tips and tricks to tackle the problem. Now, pull and assess the level of neck in relation to the acetabulum so that you know whether you require a shortening. Use a 2 size smaller stem, what I do, and the smallest neck trial and reduce. If it is reducible, then check stability, combined anteversion or coplanar angle. If it's okay, then it's okay. If not, still the time we can change the anteversion also. So definitely anteversion, and especially there's so much of distortion is there. Check the anteversion which is required to make a coplanar angle, and whether your the flexed knee angle tallies with that. If not, probably you'll have to go for a rotational osteotomy. And if it is okay, then you go ahead and see that you do not stretch it so much. So keep a finger over the sciatic nerve when you are trying to extend the hip while doing a trialing, and it comes over the time. You can appreciate if it is there and it is the sciatic nerve is getting stretched, stop, don't try to extend fully, and go for a subtrochanteric osteotomy. So you must be prepared for a subtrochanteric osteotomy. You must be prepared with a proper stem to tackle that. Accept a little shortening if necessary. Up to 1 centimeter, it will work, don't worry. Subtrochanteric osteotomy is again a very, very important tool in our hands. What we do an osteotomy at the subtrochanteric level, put up a trial and reduce it. The cut end of the distal femur is pulled and see how much of overlapping of bone is there. So that part of the bone has to be resected away. And we can keep a mark with the diathermy or pen. I think I use always diathermy to make a vertical mark. So how much rotation we want, that we can decide. And then a step cut is done. And we can lock the stem in a proper required rotation for correct. So that becomes a derotational osteotomy. And then we can use a longer stem to tackle this osteotomy as well. And there's one of the cases which I have done. So again, SROM is my workhorse for such cases because it gives me a freedom to choose my anteversion and also the offset of the neck. So that's why I use, but there are many stems which are available, which you can try, but the principle should be same. It must have a distal fixation. It must have a offset coverage, which you want to increase You don't want to increase the length, but you want to increase or make it more stable inside the sternum. So that's why the offset is important. And then the best way for atheromy is you can do whatever antiversion you want. This is not dependent on the distal stem, which we have fixed in the distal femur. So that's why. But again, there are many stems available now, which we can play with that. And always, there's no harm in checking this also. This step definitely can be avoided, but there's no harm in checking this also. And this is what the case which I showed, and I could get away without doing any derotation osteotomy or any shortening osteotomy because I had released the proximal femur very well. So that is the key. This is another case for yeah.
So we are a little short of time, sir. Please.
Yeah, I'll just rush up then. This is a case from my friend in Hugo from Colombia. So he has used a cemented stem just to override the proximal femoral deformity. It's a thin cemented stem. So that can be again. And a protrusio, again, it's a typical what Dr. Samseri said, but this case came to me after 4 months with a lot of defects in the head of the femur also. So it was a protrusio where I used an in situ cut. I didn't try to even pull out the head. And this is what I used the part of the head as a graft and could get the center of rotation out. So last, the limb length inequality is very common. I just mentioned we have to see that don't try to keep on increasing the length in the same stem, rather have multiple offsets available so that we can tighten the ligaments without lengthening the leg. That's very important. And there are so many advantages, especially the abductor lever arm becomes more powerful. So definitely it's one of the greatest boon. So the complications have to be uncomplicated by your expertise, by your handling of the soft tissue, and by preserving the bones here. Thank you. Thanks a lot, sir.
Thank you, Dr. Prashad, sir. So we now have our next speaker, Dr. Santosh Singh. Can you hear me? Dr. Santosh?
Yes, I'm here.
Please share your slide, sir. Over to you. Dr. Santosh.
Yes, I'm here. Are you able to see my screen?
No, we don't. The screen is not visible.
Pardon?
Dr. Santosh?
Yes.
So shall we move on to the next speaker? We can come back to you. Okay, we are there. You are there. Screen broadcast. Whose screen are we seeing this time? Is it you, Dr. Santosh?
Yes, it's my screen. You are visible?
We can see your phone screen. Yes. Please share your presentation. Yes.
I can see the presentation?
Yes, prosthetic. Yes.
Yes. So sorry for the interruption. So I'm speaking on the prosthetic joint infection. Hello, my
Please go ahead, Doctor. Please go ahead, Dr. Santosh. You are loud and visible.
Dr. Anup Agarwal for giving me this opportunity. I'm speaking on the prosthetic joint infection. So it is a very dreaded complication when you replace the hip. So what is the joint infection? Basically, it is defined as infection in resistance organism. So how your prosthetic got infected? Number one, by direct inoculation at the time of surgery, or it is later on, after 1 or 2 years, it may present a hematogenous shedding of the prosthesis. So what are the clinical manifestations? They are divided into 3 groups: early, delayed, and late. Early means when the infection occurs within the first 3 months of your surgery, and delayed after 3 to 24 months of the surgery. And late is also hematogenous type, where after 1 year, your patient start difficulty and pain in the joint. So acute onset is with swelling, erythema, discharge, tenderness, as you see in the acute infections. And it is also same with the hematogenous setting after 2 years. This is the acute type of presentation in early and the late. And the chronic infection, delayed infection is shown pain and more subtle symptoms like function deteriorate over the time and pain worsen over the time. As per the Musculoskeletal Infection Society criteria, these are classified into major criteria and minor criteria. The major criteria are the 2. Number 1, when a pathogen is isolated by the culture from at least 2 separate tissues or fluid sample obtained from the affected prosthetic joint. And the number 1 criteria is when there is a sinus tract communicating with the prosthesis. So these are the 2 major criteria. If your patient is having sinus tract, it means there is infection. And if you aspirated the joint or taken the culture 2 times from the 2, then it is also a major criteria. There are the 5 minor criteria like elevated ESR and CRP, elevated synovial leukocyte count, elevated synovial neutrophil percentage, isolation of microorganisms in one culture of the periprosthetic tissue, and greater than 5 neutrophils per high power field. So these are the 5 minor criteria and 2 major criteria as per the Musculoskeletal Infection Society. So these are very important because it is very difficult to diagnose when you are having a prosthetic infection. So this is the protocol which you follow to diagnose the infection. See, there is a major criteria, patient is having sinus tract, or there are some minor criteria like culture positive, leukocyte stage, synovial fluid, WBC count, and the neutrophil percentage. So you take the history, you go for the physical examination, take the X-ray of the joint, and do the serology like ESR and CRP. If they are normal, ESR, CRP is the normal, and there is a very low probability of the infection on the X-ray, on your history, on your physical examination, then most probably there is no infection. But if with this history examination X-ray finding with raised ESR, CRP, you are having any major criteria, that is, if you are having sinus tract, then it is infection is present. Suppose if these 2 things are not present, and when there is abnormal CRP only and abnormal ESR, and there is high probability of the infection on the history and examination without any major criteria, right? On history examination, you are having abnormal ESR, CRP, or you are having high probability on history examination and X-ray without any major criteria, then what you do? Then you have to go for the joint aspiration, right? On joint aspiration, if you are having all minor criteria negative, then it is decided there is infection. But if culture is positive and any one minor criteria is positive, then it is suggesting infection, or any minor 3 criteria is positive. Minor 3 criteria means raised WBC count, raised neutrophil count, leukocyte stage positive. So these are the minor criteria. Suppose if you aspirated the joint or there is no fluid came out, then what you do? Or culture is positive without the other minor criteria, or there may be condition that one or two the minor criteria is positive, or there may be condition that clinical suspicion is persistent without any positive minor criteria. If this is the situation, then you again go for the repeat aspiration. And with repeat aspiration, you send for the AFB and the fungal culture also. Suppose on repeat aspiration also there is a no minor criteria is positive, then it is less likely there is infection. But if culture is positive on that time and any minor criteria, more than two minor criteria is positive, then it is infection. Suppose on repeat aspiration there is no fluid, or there is culture negative and only one minor criteria is positive. Then what to do? Then you go for the biopsy. And do the microbiological examination of the biopsy tissues and the histopathological examination. If it is positive, then it is infection, and if it is negative, then it is infection less likely. So this is the protocol which you have to follow when you diagnose the prosthetic joint infection. So CRP has a highly sensitive, slightly better sensitive than the ASR, and the threshold for using is a 10 milligram per liter. And for the ASR, it is a 30 millimeter per hour. There are some other tests like interleukin 6 we can use, but these are the major diagnostic criteria which I have already told you. Some like radioactive indium FDG tests, they are also can be done. The synovial fluid examination is very important. As I told you, the threshold for the WBC total leukocyte count is 1100, and the percentage of neutrophils should be 64%. Then it is more suggestive of the infection. So in synovial fluid culture, in addition to informing the diagnosis of PGI, preoperative synovial fluid culture is invaluable for early identification of the infection. And the synovial fluid should be inoculated directly into the blood culture bottle, and antibiotics should be withheld at least 2 weeks prior to taking the culture from the joint. So intraoperative peripositive joint culture should be taken. It is very valuable in 30 to 80% of the cases. But a single positive culture, as I told you in the approach, a single positive culture is often regarded as the contaminant, especially in the setting of low voltage charge. If it is a high voltage charge, then it is okay. But if the organism is coming out of the low voltage, then it is maybe contaminated. So it is very important to know the type of organism is involved in your case before going the further management. Because if you know the organism and you know the virulence and you know the sensitivity of the drug, then it is easy to manage. For the radiological criteria, they are not the very sensitive or specific to the infection, I'd say, but they may help in the identification of the non-infectious causes, like presenting symptoms including periprosthetic fractures, fracture of the arthroplasty material, or dislocation. So they are helpful in non-infectious causes, but in infectious causes, they are not very much helpful. Although there are some signs like periprosthetic lucency, loosening of the prosthetic component, effusion, adjacent soft tissue gas of fluid collection, or periosteal newborn formation may suggest infection, but they are neither sensitive or not necessary because they are also present in the aseptic type of loosening. The CT sometimes may be helpful in this case, and the polyethylene wear, endosteal scalloping, radiolucent line, periosteal reaction, these are slight, very non-specific. They are more of the aseptic loosening signs. Ultrasound may have role in the, if you have abscess, aspiration of that abscess from the joint, or if you have thickened capsule, that can be detected on the ultrasound. So these are some major diagnostic tests which you can perform. And I already told you the major organism is the coagulase negative staphylococcus, and mostly they are methicillin resistant type. The treatment consists of, depending on the which type of disease you are having, which type of on which stage, there are options of the so many treatment options, like you can debride, give antibiotic and retain the implant. Second option is you can remove the implant with 1 stage or 2 stage, or you can go for the resection orthoplasty, and even sometimes you may need amputation also. So if there is acute presentation means diagnosis of PGI within approximately 30 days of the prosthesis implantation or within approximately 3 weeks of the symptom. In patient with a well-fixed prosthesis with no sinus tract, in such cases, eradication of the infections occurs in up to 70% of these patients. The mainstay of the treatment in these patients, in this group of the patient, is debridement and retention of the prosthesis. It is also known as DIAR. DIAR means debridement, antibiotic, and implant retention. We call it DIAR also. So if the infection is superficial, the wound is thoroughly irrigated and large quantity of physiological solution containing antibiotic and all necrotic substance tissue must be removed, and see whether this is connected to the joint or not. If it is connected to the joint, then do the debridement and irrigation with antibiotic solution. Hip must be dislocated to perform the procedure thoroughly. And on the modular component like head or the insert, you can change at this time. But the fixed component, you don't change. Then you take the culture of the joint root and collect tissue from the joint, and the superficial and deep periprosthetic layers are sent for the analysis of the offending organism antibiotic sensitive tissue. Following debridement with the polyethylene liner exchange and retention of the prosthesis, the initial approach to antibiotic therapy depends on the microbiology of the infection. For patients with Staphylococcus PGI who undergo debridement and retention of the prosthesis, antibiotic therapy consists of pathogen-specific intravenous therapy in combination with the rifampicin for first 2 to 6 weeks. For patients with Staphylococcus infection associated with hip, elbow, shoulder joint, subsequent therapy consists of pathogen-specific oral therapy in combination with the rifampicin to conclude the total duration 3 months.
Dr. Santosh, sir, please conclude.
Okay. So if there is a, there means 2 minutes more. Delayed presentation is in the delayed, you go for the 2 stage, 1 stage or 2 stage. The one you have a good soft tissue coverage, good bone stock, microbiology known to you, and pathogen are susceptible to the antimicrobial antimicrobial agent. Then you can go for the 1 stage. Otherwise, it is safe to go for the 2-stage arthroplasty. In the 2 stage, in the first stage, you have to remove the component, and the second stage, you implant the component when the culture is negative and the field is infection-free. During the implantation, you must take the frozen culture. If they came to the positive, then you defer for the implantation. So you change at the 6 weeks of the antibiotic, ESR-CAP negative, and when they repeat hip aspiration are negative, then you reconstruct the joint after 3 months interval. So this is I will tell you about the following. There are other conditions when you require the resection arthroplasty. When the eradication of infection is not possible by the implant, then you have to remove the whole implant and leave the patient as a excision arthroplasty. Thank you very much.
Thank you, Dr. Santosh. Without wasting time, I'd like now to invite Dr. C.S. Yadav. Please come forward and present your slide. And I'd also request the speakers to kindly stick to the time. And we're already short of time. Dr. C.S. Yadav, are you there?
Yeah.
Yes, sir. Please, thank you. Please
Please,
go ahead.
Santosh, unshare your screen. Then I will start.
Yes, sir. We can see you.
Yeah.
Yes, please.
Can you see?
We can see your screen now, sir, and we can hear you also. Please go ahead.
Yeah. Thank you, Dr. Anup Agrawal, UP Orthopedics Association, for giving me this opportunity. And Dr. Avinav just remind me around 10 minutes. So I will finish within 12. Very prosthetic. After working 22 years at Ames and 2 years at Gangaram as a head, joint replacement. I have joined Primus Hospital 4 months back. Periprosthetic fracture, they are the most common after the dislocation and infection and most common cause of revision. In primary, incidence is around 1%. In revision, it is around 4%. And it is more common in the uncemented, around 3 times more than the cemented intraoperative fractures. And now the incidence are increasing because we are doing total arthroplasty in elderly age group, like at the age of 80 or even 85, and young patient we are offering like after the skeletal maturity. And now the number of total they are also increasing. And now we are offering in grossly damaged and osteoporotic bone. So overall number of fractures are they increasing. This is the Vancouver classification. I will not go into the detail. This is for the femur. This is for the acetabulum prospect classification. Now about the factors responsible for the fractures, surgeon related, that is the most common factor for the periprosthetic fracture around the hip. Low volume surgeon, then the quality of surgery that matters. Then the implant related factor, wrong placement of the component, wrong selection of the component. And it is more common in few design. You already know these designs and they were almost withdrawn and they are not in the market. And patient related factor, they are also responsible for the periprosthetic fractures. So they are more common in the revision and inflammatory arthritis. And intraoperative factor, because of poor surgical skills, it may happen, fracture may happen, may occur during the exposure, dislocation, broaching when inserting the stem and implanting the any component. And post-operative factors like aseptic loosening, ultimately it may lead to the fracture, and malplacement of the component like varus placement of the stem, it may lead to fracture. And some stress riser, it also lead to fracture. Like here you can see this is well placed component, and it may lead, especially in the cemented hip, it may lead to the fracture over here. And this calcar fracture, they are more common in the uncemented total hip arthroplasty. Short stem, they may produce, they tend to go into the varus and they may produce Vancouver type 1, that is trochanteric fracture. And now about the stress riser, any stress riser may lead to fracture, especially if it is having more than 20% of bone diameter. So these are the hips at high risk, like all the complex primary revisions and osteoporotic hip, they are at high risk. And they are more common in the inflammatory arthritis, osteoporotic, like an elderly patient, dysplastic hip, protegio, and previous fixation, fused hip, and revisions. You can see over here, in these situations, the periprosthetic fractures, they are more common. Like here, severe protegio, patient may have fracture of the femur, even patient may have fracture of the posterior wall of the acetabulum while dislocating. So these are the all high risk hip where fracture may take place. And even your patient is also at the risk of sciatic nerve injury. And so be close to the trochanteric border to avoid the sciatic nerve injury. And fracture may also take place when you are reducing the hip, because these hips are very tight. And do pre-operative adductor tenotomy in these cases. And another, like removal of the implant, whenever you do the removal of implant, bone is weak and it may lead to the fracture, intraoperative fracture. Surface arthroplasty, there are more than 12 causes you may commit during surface arthroplasty. It may lead to the fracture neck of femur. And isoelastic and isotitan, these are the implant which leaves a lot of bone damages, or even it may lead to the fracture. So you need a lot of bone graft when you are removing these isoelastic or isotitan implant. These were done 20 years back. Now, like in this case, you have to clear this area. So trochanteric fracture is also possible, and even the hip fracture is also possible. So be carefully read the X-ray, decide your intraoperative plan, and be careful. Like loosening over here, before it gets fractured, do some intervention. Ultimately, 70%, this Swedish registry says 70% cases loosening, it may lead to the fracture. And how to make intraoperative diagnosis? This depend on high index of suspicion. Many times you do not recognize you have created a fracture. So high index of suspicion, and it may go unnoticed. Sudden change in resistance and sound. So you should be suspicious. There may be something wrong. Even X-ray may not show in if it is undisplaced fracture, because this processes may hide that fracture line. And now, how to prevent intraoperative fracture? Proper templating is very important. So if give you a estimate the size of the femoral component, side of the acetabular component, and be careful by broaching the femoral component and even implantation of the component. So overall, intelligent assessment and anticipation of intraoperative challenges. By reading the preoperative X-ray, you can avoid complication and do good preoperative planning. Read carefully the X-ray and find out on X-ray what may be problem in this particular case. So what are the principles? Follow the standard principle of fixation. Do good care preoperative planning, achieve stable fixation of the fracture as well as of the processes, preserve the soft tissue, and keep flexibility of the processes, implant, keep lot of implants and bone graft. Even allograft are required in many situations. So overall principle, basic treatment depend on the status of the implant and status of the fracture. That is most important, and this decide what to do in particular case. So modalities of treatment may be non-operative, just conservative, do not do anything, just non-bed bearing or some brace, and sometime only fixation, so you can preserve the processes. And in some time patient may need revision and fixation as well. Revision, fixation, and bone graft, especially allograft. So these are the various modalities of treatment may be required for the periprosthetic fracture. And usually fixation is a challenge whenever there is a presence of any implant or any implant like processes, and even the fixation. What happens, it may lead to the structural change in the bone. Even the placement fixation of the component may be problematic because of presence of these processes. So many times even fracture that process is stable, even then patient may need revision arthroplasty. Revision have certain advantage, like it does not have to avoid the implant, does not require stable fixation even in the poor bone, avoid potential complication of malunion and non-union if you are doing revision. Like in this case, there is a stable fracture, long distal fitting stem. We treated conservatively, fracture is almost united. Another case, stable processes, stable fracture, non-bed bearing for 2 months, fracture is almost united, no intervention. This patient processes is stable but unstable fracture, so plates and wiring and cables were used to fix it, and ultimately it has healed in 3 months. In this case, you can see this process is out, fracture trochanter is there, so long stem with the wire fixation was done. As Dr. Rajkumar told, it is not advisable to use cobalt chrome stem. I agree with him. Previously, we were using up to 2010-12 this cobalt chrome or solution stem. Now we have stopped using. We faced some complication because my bosses were using, so I were using in continuation for last 6 or 8 years. I am not using these stem. I use that titanium stems. Another
Dr.
case,
Yadav, sir.
yeah,
Reminder for 10 minutes.
yeah, okay. Another case, just distal fitting stem. And in healed, there is a no issue. Like fracture acetabulum, this reconstructed with the help of autograft. And good, another case, just simple primary fixation, primary component. Another case, you can see ETO was done. ETO is excellent whenever you are not able to remove the processes and cement and distal fitting stem. Another case, 80-year-old female, fracture over here, dislocation, this fixation and the change of processes, cement on cement was done. Now patient is walking. Another case, distal fitting stem with the fixation. Another case, this is already natural osteotomy. So implant was removed or cement was removed from over here. Then this was filled with the bone graft. Another case, this is already natural Vancouver type fracture. So removal of the component and distal fitting stem. So these are the various cases, and the few 2-3 cases above the acetabulum. You can see this is almost pelvic discontinuity type of the situation. What we have done over here, we have used whole head and we have inserted that. Then that tri-flanged cup was used. You can see now there is a osseointegration is taking place with the time. You can see these are the follow-up X-ray. Whole head was used, then corticocancellous graft. Now patient is moving. It is 2 years follow-up. Another case like here, what we did, it is severe migration of the component. What we did, we used whole head and we inserted in this area, and we used just primary cup. And you can see in follow-up, it is integrating. Now patient is fine for last 4 years. He is absolutely fine. So my philosophy is think simple, act simple, use minimum implant. That is most important. I always do in my life. So another case I will not discuss into the detail. And so overall message is number of fractures, they are increasing. Meticulous planning, anticipation of the problem, intelligent intraoperative decisions are the secret of success. Clear understanding of fracture and stability of processes is must before the surgery. Results depend on sound stability of the fracture as well as processes. Distal fit stem like titanium stem, they are required in majority of the patient. Keep all types option, all option available on the table. Bone graft, allograft should be available for the periprosthetic fracture management. Thank you.
Thank you, Dr. Yadav, sir, for finishing in time. Thank you so much. And for the question answers, we have got very little time, so I'll quickly move in. I'd like to ask Dr. Rajkumar, you initially mentioned we were very strongly opposed against aspiration in cases of aseptic loosening, whether we are suspecting that. So what is the harm in doing a aspiration side in such cases?
Like the thing is, there are so much of disadvantages in doing an aspiration because it gives false positive reports. It is not conclusive how it is taken. Aspiration is not done properly. The problem is doing an aspiration, it has to be properly done in the theater. There should not be any antibiotics given before the aspiration, at least 2 to 3 weeks before the aspiration. And then the moment you do the aspiration, if it is a dry tap, you should not inject saline inside and then do an aspiration. If at all some fluid is there, you are doing an aspiration, it has to be in theater, inoculation into a medium immediately, and then the culture has to be sent to the lab immediately, and wait for 2 weeks of extension culture period, extended culture period. Within 3 days you will not get. And most of the time in India, patients come to you after taking so much of antibiotics by the local doctors. So your aspiration is not conclusive. I strongly go by your preoperative blood parameters, ESR, CRP, how the patient's nutritional status is there, how physiologically active, and the radiological findings. This is more than enough for an aseptic loosening. Only unexplained pain with some sort of swelling and then induration in the hip, then you can. And one more point here, with so much of implants inside your acetabular plates and your cups and stems, very, very difficult to get a aspirated fluid very easily.
So what we are trying to say is that an aspiration should be done within a proper operative theater setting. It should be proper, and of course, if available, an ultrasound guidance would be helpful.
Yes, you can do that, ultrasound guided, or some places they do even a CT guided where a difficult aspiration. But if it is indicated, doubtful infection, yes, your CRP is elevated little bit, patient is not okay, but still no radiological septic loosening, then you can do. But make sure you stop the antibiotics at least 2 to 3 weeks before the aspiration. Because many times, and also you have to talk to your microbiologist that about this whole problem. Then they will look for specific organisms. And also whenever you are sending aspiration, also try to include fungus and Mycobacterium tubercle.
Or basically the
question for yes, Prashad sir.
Yeah.
Dr. Yadav sir, you were saying something. Please go ahead.
Aspiration have no role in total hip arthroplasty. I have not done even single aspiration in the hip. As Dr. Rajkumar told, it is all clinical, depending on various parameters, radiological, clinical, blood parameters. So I have not done even single aspiration. We have done thousands of total hip arthroplasty till today. But knee, it definitely is. It has role.
Question to Dr. Prashad. Can you hear me?
Yeah, sure, I can.
Yeah, question is, after combined anti-version, should we do acetabulum first and then femur in all cases of primary THR?
That's why I said, okay, we know the concept, what is coplanar, how you see that. I prefer to do in that way because doing acetabulum is easy. You cannot, we have to be guided by the child, and we have to accommodate both the pillars also. You cannot get, if you have done stem and then you try to adjust to that stem, and sometimes you are not able to get the pillar, so it becomes an unstable fixation. So I prefer to do acetabulum first and then keep a loose stem where I can change my antiversion if need arises. I can change my offset if need arises. So I get to know the axis and the tension beforehand before I put in the final stem. So this is what I prefer.
A question to Dr. Yadav sir. How do you assess for inclination and version in the cases of fixed deformities, fixed pelvic and spinal deformities in complex cases? Any tips for that?
Basically, position of the pelvis, position of the table, and the rim, acetabular rim. After the excluding the osteophyte, I decide my version. On X-ray, you can make out. Here is the osteophyte. Osteophytes are posteriorly placed or anteriorly placed, and just rule out. I try to match my cup with the acetabular rim. Then I have another clue from the floor. It should be 45 degree. My hand is anteriorly like 20 degree. So basically correlation of all these parameters, pelvic, basically pelvis, floor, and local landmark. So all I use all three.
Fantastic, sir.
But what are the requirements of changes during fixed deformities like adduction, abduction deformity, or when pelvic obliquity is there? Dr. Prashad, I am Dr. Kapil here.
I think if you are doing an ankylosing hip, then definitely because the spine is fixed, then there's a very good article by Dr. Ranawat about ankylosing hip. How you decide based on this lumbosacral angle, how much antiversion your hip will require, because then it can subluxate. It is already flexed because the pelvis is already forward facing. So how you decide? So that will be one. Definitely when your antiversion may be less and you have to adjust to the femoral first. So that's one issue. Otherwise, most of the time, the pelvic obliquity, and because I'm talking about DGH, where you do not know how much acetabulum you can fix. So get the best fit for the acetabulum, and we can always play with the femur then, because we can change the anteversion, we can change the offset also.
So one thing in relation to this anti-version question, so this is where your stem, like a modular stem, like an SROM, helps you. So you should not worry too much about the anti-version now in the femoral side initially itself. As Dr. Prasad said, your aim should be to get the correct cup size, correct positioning, and then go and address the femoral side with the modular stem. With the dysplastic hip, with the newer advantageous modular stems like SROM or Cone Wagner, you should go for an uncemented stems as much as possible as much, and then you can rotate the version accordingly on table, because that is what that stems give us the leverage. So the question of whether to do the femur or the acetabulum doesn't matter, but with this implant you can do the femur second.
Fantastic, sir. I would now request Dr. Kapil, sir, our panelist, to kindly summarize the entire session, sir, please.
It was an excellent.
It
was an excellent session after such a long period of Corona. We are meeting, so it was a nice interaction with everybody and nice lectures and good interaction. And I think everybody has explained their point of view very well in their slides. And I congratulate all the speakers for their excellent presentation, and I thank the organizers, particularly you and Dr. Anup, for arranging this and inviting me. And very well done, and keep it up. Long live UPOA. I think time is running out. We are already late by 20-25 minutes for the next session.
Yes,
so we must end. Bye-bye, and thank you, everybody.
Thank you so much,
everybody.
Sir.
Thank you.
Thank you so much, sir.
Thank you, others.
Straight away, hand over there.
Thank you, Dr. Prasad.
Thank you so much, sir. Thank you all.
Thank you, everyone.
Straight away, I would like to move to our next panelist, Dr. Imran Akhtar.
Thank you, Dr. Abhinav. This fourth and last session is about evidence-based medicine. And the panelists are Dr. Mazhar Abbas, Dr. Ajay Singh, and Dr. Najmul Huda, sir. So I would like to invite our first speaker, Dr. Dr. George Jacob, sir, to please start your first lecture.
Hello, can everyone hear me?
Yes, sir. Yes, sir. You are audible.
Good. All right.
Slide
So good afternoon. Thank you to Dr. Agarwal for inviting me to do this webinar, and thanks to all the seniors and chairpersons who are here. So my talk is on stem cells and orthopedics, slightly different from what we've been hearing all morning. I hope you find something useful in this. So I have no disclosures. First, I'd like to get into terminologies when talking about stem cells. So we all know very much that a stem cell is a cell that can differentiate into any cell in the human body, and it has the ability to self-renew itself. But just a quick note that they're not all the same. And we have totipotent cells. These are cells which have the highest differentiation potential. They can differentiate both into embryonal and extraembryonal cells. That means a zygote can give you both the embryo as well as the placenta. This is not the same with pluripotent cells, which are embryonic stem cells. They can only differentiate into cells which are within the embryo, and that is all three germ layers. And then our very popular cells, multipotent cells, the mesenchymal stem cells, which have a limited differentiation capacity and can only differentiate into cells of the mesenchymal cell line. So the cells I'm going to quickly talk about that we have available to us are the human embryonic stem cells, mesenchymal stem cells, and the newer induced pluripotent stem cell. So first, with human embryonic stem cells, they are taken from the inner cell mass of the blastocyst. So these are very young cells, they're pluripotent, they're excellent in terms of a scientific background to make a new organism or to make a new tissue. These are the best cells, but it comes with a huge amount of ethical issues. You have to sacrifice a human embryo. So you can imagine that this is just not possible when we look at human studies or clinical studies. And also because they can differentiate into any cell line, they can actually form teratomas and have high tumorigenicity. But they are young, which means they have less amount of senescence and they can give you good results in terms of good tissue regenerate. Then we have the induced pluripotent cell, which was probably a breakthrough discovery in the last 10 years from Takahashi et al. In Kyoto University. And it's basically a reprogrammed fibroblast. They were able to do it first with a dermal stem cell, with a dermal fibroblast. And basically what we've noted now over the last 10 years since the iPS cell is that every cell can be reprogrammed into an iPS cell, but the requirement or the growth factor required to make it into an induced pluripotent cell is different. So some cells tend to be better for iPS cell production than others. And more recently, I think last year, we've got a study which said that neural crest cells are in fact the best. But again, we run into this ethical problem. So the iPS cell actually solves the ethical problem by giving us highly pluripotent cells, but making access to these cells easy. We are able to get a good quantity without much risk. Taking a dermal cell is easy. We can take a lot of fibroblast cell, but the problem is these cells are relatively older in their cell life. They're somatic cells. They're not young cells, which means they've gone through many cell cycles and they can in fact lead to tumorigenicity. And now my talk will mainly be on MSCs because this is what we have to play with in the clinic these days. But mesenchymal stem cells seem to be the safer option. They seem to have what we need in terms of availability, and they have somewhat the stem cell nature that we need. So the common sources that we utilize over here have been marrow, the most historically used source. Then we've come on to adipose more recently, and then now synovium. And like I said, all MSCs are not treated equally. When we look at the bone marrow, you get a good cell if you actually get a cell, and that they're quite osteogenic, chondrogenic, and adipogenic. But the chance of getting a good amount of cell from a bone marrow aspirate is very low because we don't get much cell harvest in a bone marrow aspiration. With adipose, we get a great amount of cell. Doing a liposuction, you get a huge amount of cell, but the cells are not very good. They don't differentiate well, especially chondrogenically. And then we have synovium, which is actually very easy to harvest during an arthroscopy. We can take a very little amount of tissue. It doesn't have much donor site morbidity, and they're extremely good at proliferating. But the problem here is it needs to be two-stage, and you need to expand the cells. So even Nakamura's group now has actually taken synovium from rheumatoid patients, arthritic patients, and normal patients, and the proliferative capacity of these cells has been exactly the same. So synovium may be the key to the future. So the advantages of MSCs, they're easily available. They have low immunogenicity, which means we can use them allogenically. They're multipotent, and they have great paracrine functions. So just this diagram over here explains quickly what they can do. And MSCs secrete and communicate via exosomes, which also have paracrine functions. They have their own paracrine functions, secreting growth factors, anabolic factors, and anti-inflammatory factors. They have some amount of endogenous cell recruitment where they can bring more stem cells to the site of injection. And they also have anti-inflammatory functions. So now coming to cell processing, this is what I was talking about with regards to synovium. So we can have minimally manipulated MSCs, or we can have culture expanded and differentiated MSCs. With minimally manipulated processing, we're looking at centrifugation or company-based protocols, where you just have this one-step surgery or solution. You take the cells from the patient, you process them in this company-based method, and then you deliver them. The problem with this is there's no standardization and there's no quality control. You don't know what you've given the patient. You've just taken what's available within the patient and given it back to them. Whether it's more concentrated, we don't know. And without actually doing some kind of quality control, it seems like it's not very objective. But this is considered safer because it's autologous. There's no regulatory concerns. It's what we are allowed to freely practice in India right now. Now, culture expanded, we can actually take these cells, take them to a lab, expand them, differentiate them, do some quality control, confirm the amount of cell number, standardize the whole thing, and give it as a proper objective medical treatment. Except this is now expensive, it's two-stage, and there are regulatory concerns. Only certain labs are able to do this, and only certain centers have the facilities. Now coming to culture conditions. Lately, we've been playing with various culture conditions to try and give us better cells, better regenerate. So not only can we play with the source of the cell, we can also play with how we culture the cell. So most obvious is culture media. As we've all learned in microbiology for centuries, every culture media has a different way of reacting to the cells. But we've also recently found that we can use bioreactors. These can apply different oxygen tensions, different amounts of pressures, and a group in Tokyo are now actually doing anti-gravity cultures. So this gives you a better stem yield. and the cells have more stemness, which means you can differentiate them into a chondrocyte or tenocyte, whichever cell line you're trying to go for. Also, we can use growth factors and decellularized ECMs and biomaterials, which allow for some kind of tissue microarchitecture where you can feed these stem cells into like a small kind of scaffolding, which will allow for the cells to attach and grow better once you put them into the body. Then the next factor that we can consider is delivery. This can either be locally given to a joint as we would in a knee, and commonly the studies that we do see these days is just a local stem cell injection, or systemic in certain other conditions like osteogenesis imperfecta. So locally, you can also consider doing tissue engineering using biomaterials, and these can be with scaffolds or scaffold-free. And systemically, this can be delivered by injections or by infusions. Now, just applications, the more exciting part of this talk, we've got stem cell uses in cartilage, osteoarthritis, meniscal surgery, fracture, osteonecrosis, tendon, osteogenesis imperfecta, cord injury. They've all been reported uses, with literature being probably the highest in cartilage. But today I'm going to be focusing mainly on the bread and butter of orthopedics, where we see more cartilage injuries and osteoarthritis. So majority of the studies, in fact, all clinical studies have used MSCs in fear of the other cell sources having some kind of tumorigenicity. So just quickly coming to cartilage, I went through literature and I found 3 systematic reviews. Basically, at the end of these reviews, what they could conclude was that the MSC therapies in cartilage regeneration were safe. They improved short-term PROs, patient-reported outcomes, but the MRI scoring was irregular. Objective data is not available. And what they did find, though, is that the patients who had 2-stage treatments, that is where you were able to expand the cells and do some form of quality control, those patients or those results seem to be better. But again, these are short-term results. The longest follow-up that we have in these reviews is about 21 months. Now coming to synovial cells, Nakamura's group has actually used synovial MSCs to form what's called tissue engineered construct. Over here, if you look, there's like a small little chewing gum-like tissue that's been formed. That's just with a high density synovial MSC monolayer culture. And the cells all come together and shake hands and become kind of like one tissue. And this tissue can be implanted into the cartilage defect, and you can get a good cartilage repair. So over here, you can see the clinical results, which was actually done in a human trial in about 7 patients. And the randomized control trial is currently going on. But you can see a very good cartilage repair over here. And these are the arthroscopies post surgery as well. And coming to the histology, you can see there's a good amount of proteoglycan, and the tissues have incorporated well with the subchondral bone. So synovial MSCs may be the future, and we may be looking at a new therapy coming in with this tissue engineered construct in the future once the RCTs are over and we have some more level 1 data. Coming to osteoarthritis and MSCs, we've commonly seen bone marrow aspirate concentrate injections, microfragmented adipose, that is SVF or lipogems, and then we have culture expanded cells. So the idea here is that these MSCs, because of their anti-inflammatory role and their ability to recruit and regenerate more MSCs, they may be able to be given in early stages of osteoarthritis to kind of reverse the inflammation because of the imbalance that's happening in the joint. So studies here again have said that it's probably got better use in early stages of osteoarthritis. Once you've got advanced OA, it's probably not possible to reverse anything. It's safe, it's autologous most of the time. And as I said earlier, MSCs are safe to be used allogenically. So we haven't seen any adverse reactions in most of the literature. And there are some studies to suggest that more cells and more doses result in a better response. But again, the main issue here is a heterogeneity in the studies. There is no standardization. So every study has a different protocol and they have a different additive with the stem cells. So we're not really sure what's bringing about the improvement. Coming to meniscus, MSCs and meniscus are usually given as an adjunct to repair. There's a lot of preclinical data available with some excellent results, but sadly not enough clinical. Clinical results are ambiguous. Usually the follow-ups are not objective. We have MRI scans or second look scopies in some studies, but we don't in many others. And we just look at subjective scoring outcomes of the patients. Ideally, they've been recommended to be used for augmenting degenerative lesions, not in a fresh meniscal tear. And now we're coming into new technologies where we can wrap it with a scaffold, a collagen-based scaffold, or even using a tissue-engineered construct, which has been done in a porcine model here. I put up a couple of images. The same group has actually put tissue-engineered construct into these defects, and we've seen some excellent healing. But again, this is all preclinical data. Fracture healing. So as we know, we've actually seen a lot of studies which show that hematoma contains a lot of stem cells endogenously. And a lot of studies have used bone marrow aspirate concentrate for non-union. And this is usually taken from the iliac crest or the tibial tuberosity and then centrifuged. Earlier on, they were talking about a good amount of cells from the tibial tuberosity when compared to the iliac crest. And then there were different methods of procuring the aspirate. All in all, we found that you don't get enough cell. It's quite a very low amount of cell, and it just doesn't have enough cell in there to create an adequate response, even with concentration. So it's better to actually consider doing a two-stage procedure. Results, it appears safe. We've not seen any adverse reaction. Results have been ambiguous. Some show union, some don't show. There's no quality control here. And like I said, these therapies may improve cell homing, so you may actually get more endogenous stem cell supply. It may increase the cell population and angiogenesis at the fracture site, but we aren't really sure.
Sorry to interrupt, Dr. George Jacob, sir. We are already running short of time. Please summarize, sir, please.
Yes. So coming to future therapies, we may be looking at better cell culture and expansion, more tissue engineering, and hopefully we'll be able to use and tap into these newer sources such as the induced pluripotent cell and the human embryonic stem cell and exosomes into the future. We may even be looking at a next generation ACI where we actually have these younger stem cells where we can use them instead of using chondrocytes taken from the patient's knee. So the bottom line is we need more data and randomized control trials. We need standardization. MSCs remain an investigational agent when using for clinical therapies, and it's difficult to predict objective outcomes. And most importantly, we should use them ethically. We shouldn't be using them without that. And all I can say for now is so far, so good. Thank you.
Thank you, sir. I request next speaker, Dr. Raju Vash, sir, to please present your lecture.
Thank you. I would like to share my screen. Good afternoon, friends. In next 10 minutes or so, I will take you away from the clinical work which we have been discussing since morning, but I will also tell you how you can involve your clinical work into research and publication, which is so important, and it gives a lot of credit for your good clinical work if you are doing both these things complementary to each other. It is
please,
known for that,
sorry to interrupt, sir. Sir, screen is not visible, sir. Please share your screen, sir. Dr. Raju Vash, sir, please share your screen, sir.
My screen is not visible?
No, sir. No, sir. Not yet, sir.
I have shared it.
So then please unshare and share again, sir.
Just a moment. Can you see it now?
Yes, sir. It's starting, sir.
Sorry about that.
Now it is visible, sir. Please
so,
go ahead.
It is a known aphorism that if you do not publish, you may perish. But I would say that nowadays, if you publish, you can also prosper. And hence, we should all try to involve our clinical work and disseminate the information to the world by publishing, and then we can prosper ourselves and help the other people. So why publishing? Because scientific writing, any article, is the major and final product of any research of a scientist. And its highest value is reached only when the scientific information is published and becomes a pool or a fund of knowledge for the rest of the world to follow. There are several advantages of publication. Not only it gives pleasure and sense of satisfaction and achievement to the author, but it also provides an additional line to your CV, which is very important, especially for young people. You can share your ideas and results with your colleagues and rest of the world, which leaves a record permanently in the world pool of literature, which can be used by others. It gets you a name in that field of specialty and build your academic reputation. It may also help your institution by improving its ranking And overall, it's a very important career step in your profession nowadays, especially. And you can see how important is research and publication. And if you do research and publication, you get lots of awards and recognition like this. But unfortunately, I found that research is usually repulsive for most clinicians because of several factors, which I will discuss soon. But once you have publication, then it becomes addictive. So if you have got a couple of publications under your belt, you may try to do many more in future. But if you have not done or tasted it success, then you may not be able to do it. This is my career graph, which describes what I have said just now. You see, initially, I had very few publications during my residency, which was essential to get me some job. Then during initial years of practice, we had almost no publications, but then these publications started to increase, because once you publish a few articles, you get more ideas, you have more clinical work to present, and you get more recognition. So it's a vicious cycle. But there are several barriers to publication, the most important being the mindset. Most people think it's not my cup of tea and I cannot do it. It is impossible because I'm a busy practitioner. I have shortage of time. There may be language related barriers. There may be difficulty in communicating your work and ideas to your colleagues and rest of the world, because it opens up for potential criticism of your work. And the research methodology in the recent past have become a little bit more complex, and more higher level of evidence of papers like systematic reviews, meta-analysis are being preferred over simple research like case reports and retrospective analysis of the data. There are some special barriers, especially for people like researchers in India, because most of the big journals are now asking for article processing charges, which may be in few $1,000s for publication. And moreover, now English language is usually preferred all over the world, and they want us to publish or send our manuscript in very high quality English, which may not be possible at our end because of no support. And these journals often ask for huge amount of money to improve your English in the manuscript. So these are two important barriers which we all have to face. Why it is difficult to publish? Because writing is a skill, and whatever the language may be, if you are not tuned to writing, it may be difficult for you to publish. And getting published is also skill, because not all authors or writers get published. The rejection rate in most of the reputed journal is around 80 to 90%. And not all research is new or sufficient or of sufficient scientific interest to the editors and reviewers, and hence it gets rejected. It is often thought that positive results are easier to publish, and hence most authors prefer to present their positive results. But nowadays, trend is changing. Most journals and editors actually like negative results if it is true, because that gives you much more important message than glorifying your study only. Scientific journals have different requirements, and one must follow these requirements according to the journal type. There are several tips and tricks for busy clinician to go into research and publication. And first and foremost is to develop an aptitude and passion for research and publication. You must learn or identify your jewels. Jewels, I mean, we all do very complex cases, we all see very difficult cases, but we do not know how important these cases and procedures that we are doing, and these are our jewels. If we read the literature, you will find such cases are not being described, and it is very important that you do it. And most of the senior authors who are in practice for 25, 30, 40 years, have not seen something and they are seeing it for the first time, it means it can be rare and it has to be investigated. You must develop a habit of reading recently published articles on regular basis. And for that, it is very important and easy nowadays to enroll to table of contents of many important journals that will send you every month the list of publications that are happening, and you can choose whichever you may find. Initially, it is a good idea to find a mentor who is into research and publication to help you out and to guide you how to do this publication. As I said, it is difficult to get published, and there are several tips and tricks which manuscript get published. Your research should be novel. It should give a clear, useful, and exciting message to the editors and reviewers. It must be presented in a constructive and logical manner. And the reviewers and editors should be able to grasp the clinical significance of your research easily rather than making it very complex, because editors and reviewers are all busy scientists. They are also clinicians, and if they have to spend a lot of time in trying to understand what you're saying, may subject it for rejection, and hence try to make it simple, to the point, and as per the journal requirement. Then once you have done your research and you have written a paper, it's a very important question where to publish, where to send it for publication, because now there are so many journals in your each specialty that you can send the journal, but you must try to take few things into consideration, right? What is the theme of your paper, which any journal would take? Consider the audience and readership where you want to address your research, and consider the reputation of that journal by its impact factor or site score, because higher impact factor obviously are read and cited more, but they are more difficult to get published your research. And there are several publishers' website where you can go and put your abstract and keywords, and they can suggest you many journals in which you can put your research for publication. So how to set up the clinical practice and research in your practice? You should incorporate your research tool from the very beginning into your practice, follow the important clinical guidelines, and keep a meticulous record of all the cases that will help you in doing future research. There are several motivations for publication, because it gives you fame, it gives you recognition by your peers. Some people can make fortune out of it because of promotions, grant, and application for research funding that is applicable more in the developed world. Moreover, it is our responsibility to the society as a taxpayer-funded research to help patients by our research and contributing to the progress of the medical science for the present and for the future patients. But the greatest enemy of knowledge is not ignorance, it is the illusion of knowledge in which we all are living. We think we know everything and there is no need to further upgrade ourselves. But if you want to do that, first you have to unlearn what you have learned before, and then only you can absorb new things and relearn newer things and do much more better research. So the evolution of researcher is like this. You first publish a paper, thinking that if you do not publish, you may perish. And then you try to publish in better journal of higher impact. And then you publish it more frequently in a higher impact journal, because you think if you don't do it, you may not be, you won't be, may not be perish. Publications, as I said, is not that easy, but it is done by people who are living in the world only. Yes, sir.
Sorry to interrupt, sir. We are running short of time, so please summarize, sir.
Yeah, let me finish 12 minutes.
Yes.
12 minutes.
Yeah. It takes time because it gets easier, but it gets easier with practice. So don't wait any longer and start writing the paper now. There are several pitfalls regarding publish and perish because you spend a lot of time. You may ignore your clinical practice or other commitment like teaching and mentoring. And there may be perpetuate bias in the academic institution, like male and female. Females are less preferred to research and publication than males. To conclude, it is important to balance your clinical practice and research to get the maximum benefit out of it. The research is a fact of life and is vital to the growth of science and to career progression, especially in this era. And publishing is now not optional, but it is obligatory for all of us. Thank you very much to UP Orthocon for giving me this opportunity to present my thoughts about research and publication.
Thank you, sir. Now I request our next speaker, Dr. Ashok Shyam, sir, to please give a presentation, sir.
Okay, good afternoon, everybody. I hope you can see my slides and hear me.
Yes, sir. Yes, sir. It is visible.
So first of all, thanks to UP Orthocon for inviting me to speak on these two topics. These are my resources that I've used to prepare my presentation. Yeah. As per Hippocrates, our first law is first do no harm. This too applies in research, because in my further slides, I'll show how doing bad research does more harm than anything else. There are various aspects of frauds in publishing. We have from authors, reviewers, editors, publishers. We have them in reporting, authorship, but specifically in plagiarism, and now a newest threat in form of predatory journals and pseudo journals. So let me start with plagiarism. Coming to the point directly, unreferenced use of published or unpublished work belonging to other is what is plagiarism. This is how World Association of Medical Editors define it. Plagiarism is when 6 consecutive words are copied from any other article and pasted in the manuscript. So that is what plagiarism is in short terms. Many a times it is unintentional. So that's what I have found, that many of the articles that I review and get back to the authors, speak to them, I find that it is quite a bit unintentional. They don't know these definitions, and they don't understand that even though they have referenced the article, copying the entire sentences or paragraphs from the articles is still a plagiarism. Few times it is intentional also, but nevertheless, whether it is intentional or unintentional, it is unethical in both ways, in all ways. So we have to know about this. If you're submitting, writing, publishing research, you have to know about this, get educated, and be careful about it. Ignorance is not the same as innocence. So especially in academic world, it can be in direct form, mosaic form, self-plagiarism. So direct is when you directly take the entire sentence and paragraph and put it up. Mosaic is you say change the subject, object, and present the same sentences. Self-plagiarism is plagiarizing from your own articles or own textbook chapters. You cannot even copy paste the same things that you have already published in an article or a chapter. You have to cite properly, and you have to check for plagiarism checker. Now, what is plagiarism checker? This is a free tool that is available on this website called Small SEO Tools. Okay, it is a free plagiarism checker, which I find is one of the better ones. There are a lot of free plagiarism checkers that are available. You can put your text here. Okay, you can put your text here, maybe 1,000 words every in parts, and check for plagiarism. So it gives you where it is copied and pasted from. So it exactly tells you which article, what sentences are copied and pasted. Grammarly is another good tool to invest in if you're writing articles. It does plagiarism checker also in the paid version, and it gives you very good grammar check. So it is, I think, win-win for anybody who is into writing articles. So this software is a must if you are writing and publishing articles. So plagiarism, you can rephrase and you can cite, but both of these are not an excuse for plagiarism. Okay, even if you rephrase the sentence slightly and put your citations, it can still be considered as plagiarism. So how to deal with plagiarism? What I do and suggest to people, uh, generally they plagiarize from an article which they find is most impactful in their literature review. They copy, paste the same sentences from that particular article because they find that that sentence fits perfectly their manuscript. What I suggest to them is create this Excel sheet of all the review articles that you have reviewed, put sentences into various columns like I've shown here. In the end, you will have a literature review Excel sheet. This is what we do even for systematic reviews. But this is a quite rough in the sense that once you put all the sentences and inferences in the column, you have an overview of the entire literature review you have done in one single Excel sheet. That will help you write sentences in a much more proper way rather than copy pasting them. Okay, so try this method. It will help you in dealing with plagiarism. You have to be aware of it, that it is easily detectable plagiarism now, and it has serious implication. Even if your article is plagiarism is missed by editors, reviewers, and it gets published, after publication, people who are reading it can point it to the editors that this thing is plagiarized, and your article can get retracted and you get a bad repute in the academic world. Let's move to the second topic of predatory journals or pseudo journals. Okay, sorry, yeah. So this is the definition of predatory journal. They are mostly into self-interest at the expense of scholarship. They are characterized by false and misleading information, deviation from best editorial and publication practices, and lack of transparency, especially indiscriminate solicitation. I am sure all of you must have received emails from various journals asking you to submit your articles. All those journals are predatory journal, irrespective of, unless specified otherwise. False or misleading information in form of they claim indexation and they claim high impact factor. You have to check from where they are indexed and what impact factor they are looking at. Deviation from best practices, no peer review, no plagiarism check, no grammar formats. So a lot of spelling mistakes in the articles, plagiarism is not checked at all, no peer review. You immediately submit the article, you get next day a payment link, you pay the money and it gets published. So that's the format for these journals. Indiscriminate solicitation through emails, social medias, they even give you a phone call or send you SMS for publishing. So how to spot these predatory journals? There's a very good article by Victoria Glasson. She gives 6 steps in spotting these journals, which I am going to just detail it here. Okay. First is always check the journal website thoroughly. Might be many spelling mistakes in the journals and the links that are not working. So that's a sign of a predatory journal. Second is check if the journal is member of any of these bodies, DOAJ, COPE, OSMA, STM, or if they're claiming that they are a member of these bodies. You can check the link that they have provided on their website or go to these publisher websites or indexing website and check if the journal is there. Third is check journal's contact information. I've seen many journals that are published in India, but they give contact information of UK or USA, which is just a post box number or something like that. And even the names of the journal contacts are foreign names, are names from US or UK or Europe somewhere. So be aware of that. But the journal is just publishing somewhere in Kolhapur in Maharashtra. So that's I've seen very frequently. Do they have peer review process and publication timeline. So they have they detail their peer review process and have they put up timelines of how many days the peer review will take. Read through the past issues of the journal, see if there are any mistakes pointed out, see if they receive letter to editors. The editor is a very good format to check if the journal is predatory or not. Only good journals receive letter to editors. Additional consideration like the payment thing, if they are asking payment directly on submission and not on acceptance, that is a sign of predatory journals. Then you see the editorial board, see who is on the editorial board, who is the editor. Are their profiles linked to LinkedIn or ResearchGate? Even check the social media profile of the journal. Are they posting on social media? Yes or no, and check the post. Okay, so that is also how you can distinguish a predatory journal. Now, in both these things, the plagiarism and predatory journal, you have to remember that research is pursuit of knowledge for social and scientific advancement. It is not for personal gratification, but to help our patients get better treatment. By plagiarizing, by publishing in journals, just paying money and getting it published, is not going to help research, is not going to help our patients. So please don't do that. You have to understand what research means sincerely, right? Any misconduct will generate ripple. Any bad research that you publish will be cited by another study, or another group of patients may undergo the same method that you have propagated, and it may harm patients more than anything else. So please be aware of this. Please be very, very careful of what you are publishing. Publication or scientific research is your moral, social, and scientific responsibility, but most importantly, it is measure of your integrity, of your own integrity, of all the author's integrity. So you have to maintain that and do not go or follow any unethical practices. Thank you very much.
Now, next talk is by Dr. Devendra Singh, sir.
Hello, everyone.
Please share your screen, sir. Dr. Devendra Singh, sir. Please share your screen.
Is everybody can hear, see my screen?
Yes, yes, please go ahead.
Thank you, whole team of UP OrthoCon, for inviting me, because I am a person from a different field, but though the patients are common for everyone. I am Dr. Devendra. I am consultant interventional pain management at Sahara Hospital, Lucknow. I have been practicing interventional pain management for last 1 decade, and so this was my first time when I am participating in an CME, where the organizers and other speakers are out of my domain. So thank you everyone for inviting a pain guy in a academic event which is organized by orthopedics people. Thank you, Dr. Anup. So today, because the topic given to me was recent trends in pain management. So I'll be very fast sharing few slides of recent advances in generalized whole field as a pain management, and some special recent advances which are being practiced by an interventional pain physician. So this is the first topic, that is percutaneous transfemoral endoscopic disc decombination. We all have patients with the back pain and radicular pain. We get an MRI done. We see either there is a facet joint arthropathy or sacroiliac joint arthropathy, or there is a degenerative disc, or there is a degenerative spine as a whole, or there is osteoporosis. There are many causes of low back pain. And there are fewer causes of low back pain radiating to the lower limb. But if we see the patient of low back pain radiating to the lower limb pain, most of the time we see there is a degenerative disc and a mild compression of lateral discs in the exiting roots. But sometimes the patient don't respond to the conservative measures. So as a pain physician, our next step is to go for a transforaminal neuroplasty. And if the patient response is okay with transforaminal neuroplasty and the pain doesn't have a recurrence within 6 months, then we repeat the procedure and probably the patient is comfortable for a longer time. But if the disease is progressed and we see that the patient has returned with the same problem, then we step to the next procedure, that is percutaneous transforaminal endoscopic disc decompression. This is a minimally invasive procedure where understanding of foraminal anatomy and pathophysiology of back pain and leg pain are very important. There are specific indications and contraindications. I'll quickly introduce. It is a interventional or surgical management of back and leg pain involving and changing due to the better understanding of pathoanatomy and well coordinated with pathophysiology. And the technique which I am showing is an inside-out technique of transforaminal endoscopy. And it is a safe technique, precise, it provides a basic access to the disc and the foramen to cover the large spectrum of painful pathologies. So shortly, if you see, this is an anatomy. This is a Camben's triangle. Here we have to enter the space where we see that there are annular tears. This is a classical where there is a posterolateral tear in the disc and there is a compression of exiting root. This is an exiting root and this is a traversing root. This is a supraarticular process and this is a intervertebral disc. So we have to enter into this area. This is the safest area where we get the extruded fragment from the disc and we can decompress it and we can decompress the nerve. So this is a cadaveric flag. We go on to the next. So how the pathophysiology is there. There is initially an annular tear, then there is leak and cause inflammation around the nerve root or the dorsal root ganglia. Then there is annular weakness which leads to the subsequent herniation through the tear. And so our target is to remove the embedded disc fragment in the tear and to allow the torn annulus to heal. If you see the Camben's triangle, this is a Camben's triangle and this is our approach. This is totally under C-arm guidance. And it is a site of SS. We first place the cannula here, then we place the guide wire, and then we place a dilator over the guide wire, and then we place the working sheath. And through the working sheath, we place our endoscope, which is a 30-degree endoscope, and then we can remove, and through our forceps and the cutters, then we remove this extruded fragment. And most of the time, we are able to pull through the tail of the extruded fragment so that the whole of the fragment can be taken out. And this is the technique of portal of entry. It is almost if you see in average Indian size, it is 10 to 12 centimeter from the midline and about 20 to 30 degree to the angle from the base. And this is how the patient is placed in the prone position. It is under strict aseptic precautions. It is sterile draped, and then this is the C-arm, and this is the image which we can see. This is a classical example where we do endoscopics, and you can see here at L4, L5 there is an annular tear which has crossed the margin, and this you can see there is a compromised lateral recess and the exiting root of there is a compromise here in the L4, L5 level. So we have to decompress this from the left paracentral approach. And this is how we place a needle, and this is how we place a guide wire, and this is a dilator. This is a dilator which we placed, and over the dilator we place a working sheath or the cannula, and then we place the forceps, and then we remove the fragment. This is how exactly how the setup is made, and this is how we place the needle, and then we place the guide wire, then we place the sheath. This is the dilator, This is the sheath. This you can see, this is a working sheath, and through this we place a endoscope, and then we remove the fragment. Actually, and this is the procedure where we remove the fragment, and the patient is what I want to say. The patient is immediately there is which the SLR which we test pre-op, and there is a remarkable difference in the SLR of which after we do the procedure, and the patient is relatively pain-free, and it is a daycare procedure. We usually discharge him in the evening if there is no other contraindication for a daycare discharge. And this is an excellent procedure through which the patient is saved from the laminectomy or the bigger surgeries which have the larger impact over the quality of life in the longer term. So this is what I wanted to present. Listen, if any questions or any queries from the
Thank you,
audience.
sir. So if panelist allows me, should we take questions, sir? Dr. Ajay Singh, sir?
Yeah, 1 or 2 questions at the most.
Yes, sir, Dr. Raju Vash has asked Dr. George Jacob, sir, that what is the regulatory approval status for the use of stem cells and other cells in India?
Right now, I don't think there's any regulatory status in terms of what you're actually allowed to do. As long as you've got patient consent and you explain a very minimally manipulated cell is allowed to be used. I've seen some people using amnion and chorion around ACLs now. I'm not entirely sure about whether the governing bodies have a stance on that. But as far as I know from where I'm working here in South India, we're not allowed to do anything as far as ACI. And when it comes to using bone marrow, we just allowed to centrifuge it and deliver it to the patient as long as the patient has given us consent and they know that this is still an investigational agent. I was in Japan for a while where it's very transparent. They're pushing them as much as possible to go ahead and do all of these things. I think we need to catch up, and hopefully we will soon.
Thank you, sir. Now I hand over the mic to Dr. Ajay Singh, sir, to please summarize the session. Dr. Ajay Singh, sir. Dr. Ajay Singh, sir.
Yeah.
Please go ahead.
Yes. Thank you very much, all the speakers. We have finished this evidence-based medicine session. And now I would like to invite the UPOA Exchange Fellowship fellows from the Madhya Pradesh, that is MPOA. And I welcome Dr. Saket Jati, who is the Honorary Secretary MPOA. There are 2 fellows, Dr. Pratik Pathak and Dr. Vivek Singh, who will present their work. The time allotted is 6 minutes to each, and I request both to present. First, Dr. Pratik will present, then Dr. Vivek, and only 6 minutes are allotted to them. Imran, please coordinate for that.
Dr. Pratik, sir. Dr. Pratik?
Yes, sir. Yes, sir. I'm online.
Please share your screen, sir.
Yes,
please
sir.
share
Thank you, sir. Good afternoon, faculty members. Is my screen visible?
Yes,
sir. Yes, sir.
Go ahead.
Please go ahead.
Thank you for giving me this opportunity. My topic for presentation is evaluation of radiological remodeling using Bowman's angle in supracondylar fractures of the humerus managed with either closed or open reduction and internal fixation with KVAS. Supracondylar fractures of the humerus are one of the most common fractures occurring in children. They are categorized as extension or flexion type of injury, the extension type being more common, accounting for nearly 90 to 98% of the cases. Closed reduction and percutaneous pinning promises to be the paramount method of management at present. The aim in treating these fractures is to re-establish the anatomy of the distal humerus with adequate stability to permit early painless functional elbow range of motion. The rotational or medial tilting of the distal fragment are responsible for the angular deformity, whereas some believe the growth disorders of the cartilaginous complex of the distal end of the humerus induced by the fracture itself may be causing it. Our aim in this study was to study where there is bone remodeling in treated cases of supracondylar humerus fractures. Bowman angle has been validated as one of the most reliable parameters in radiological remodeling of the displaced supracondylar fractures of humerus in children. Now, what is the Bowman's angle? The Bowman's angle is created by intersection of a line drawn down the humeral axis and a plane one along the growth plate of the lateral condyle of the elbow. It has been found to range from 64 to 81 degrees, and it increases slightly with age maturation and has no sex variation. Bowman angle of the contralateral elbow should always be used for comparison. Now, this is a study done by Silva et al. To study the inter and intra-observer reliability of the Bowman angle of the humerus in children with supracondylar fractures of humerus. They concluded that Bowman angle of the humerus is a simple, repeatable, and reliable measurement that can be used for determination of the outcome of supracondylar fracture humerus. Now, this is a study done by Smagic et al. To study the correlation between the Bowman's and the carrying angle in children. Bowman's angle, they concluded that Bowman's angle correlates well with the carrying angle and can be used for the indicator of potential occurrences of cosmetic complications. This was a prospective study done at Sri Aurobindo Institute of Medical Sciences, Indore. It consisted of 30 patients and who were operated between September 2018 to August 2019. We included patients between the age of 3 to 12 years who had Gartland type 2 and type 3 fractures and were surgically managed. If they were concomitant fractures of the same limb, we excluded them. We also excluded Gartland type 1 fractures and patients who were conservatively managed. These were the various spinning configurations we use. That is 2 lateral and 1 medial, 1 lateral cross spinning, and 2 lateral divergent wires. Post-operatively, the patient was put in a slab. The K-wires were removed at 4 years, and we followed up the patient at 3 months, 6 months, and 1 year. And at 1 year, we took a full-length radiograph of the opposite limb as well. In our results, we found that 26 out of 30, that is 86.7% of the patients had an increase in Bowman's angle post-operatively compared to the unaffected side, while 4 had a decrease in Bowman's angle. Now, the mean increase in Bowman's angle with cases in increase was 3.22 degrees with a standard deviation of 3.38 degrees, whereas the overall mean change in Bowman angle was 2.93 degrees with a standard deviation of 1.14 degrees. Now, the comparison of the Bowman's angle of the affected side between 6 months follow-up and the 1 year final follow-up was at 6 months Bowman angle was found to be 79.03 degrees with a standard deviation of 3.32 degrees, whereas at 1 year follow-up it reduced down to 78.53 degrees. So this was found to be statistically significant. Now, comparing the Bowman's angle of the unaffected and the affected side at final follow-up, that we found that the unaffected side had a slightly lesser Bowman's angle when compared to the affected side, which was statistically significant. These are graphs showing the comparison of the unaffected and the affected side Bowman's angle. These are my representative cases. This is the pre-operative X-ray, immediate post-op X-ray. This is the 4 weeks follow-up. This is the 3 months follow-up. This is the 6 months follow-up, and this 1 year final follow-up with the unaffected limb X-ray as well. These are the representative clinical images. This is my case 2, immediate post-op X-ray, 4 weeks follow-up, 3 months follow-up, 6 months follow-up, and 1 year follow-up. These are the clinical images. In our study, 1 patient had superficial K-wire migration, while 3 had superficial infections, which were treated with oral antibiotics. Majority of the patients did not have any complications. We analyzed our collected data and studied them with other series of similar topic. We achieved close reduction in 29%, 29 patients out of 30, while in 1 patient we had to go for open reduction after failure of close reduction. The majority of our patients were male between age of 5
Dr.
to
9. Pratik, sorry to interrupt you. We are already late, so please conclude, sir.
Yes, sir. Yes, sir. There was in our study, we found that there was a considerable remodeling of the Bowman's angle between 6 months and 1 year, but we require a longer follow-up for study of the further potential for movement. There was also increase in Bowman's angle was mostly seen in the posteromedial displacement, whereas posterolateral displacements had a decrease in Bowman's angle. This is a graph showing our comparison with other studies of similar topic. Nikolic et al. Also did a similar study, and they have concluded that bone remodeling is possible in treating after treated cases of supracondylar fractures of humerus, but the remodeling was relatively low. This is a study done by Gamble et al. They have also concluded that children have the capacity to remodel radiographically. Based on our study, we conclude that we have observed a favorable remodeling of Bowman's angle between 6 months and 1 year, but a larger sample size and a longer follow-up may be required to ascertain this fact. Thank you. These are my references.
Thank you. Now I request Dr. Vivek Singh to please present your presentation. Dr. Vivek Singh.
Yes, I am here, sir. Am I audible?
Yes, you are audible.
Okay,
Dr. Pratik, please unshare.
Yes, sir.
Yes, please share your screen, Dr. Vivek Singh, sir.
Yes, sir. I'm doing the same. Is my slide visible, sir?
Yes, the screen is visible. Yes.
Is my presentation visible, sir?
Yes, please go ahead.
Okay. Hello, everyone. Thank you for allowing me to present a paper over here. I'm Dr. Vivek Singh Dhagar from GR Medical College, Gwalior, presenting a paper on a comparative prospective study in between cemented hemiarthroplasty and osteosynthesis as regards to the functional outcome and survival and fracture neck of femur in elderly population under the guidance of Dr. R.K.S. Dhagar, President of MP Orthopedic Association. So, as you all know, the optimal surgical treatment for the displaced femoral neck fracture remains controversial, especially in people aged above 50 years. The two treatment options includes prosthetic replacement. Either you replace the head or you fix it with osteosynthesis. The proponents of prosthetic replacement argue that the replacement of femoral head eliminates the necessity of revision surgery due to ABN and non-union, both of which are a very difficult situation to manage following osteosynthesis. The aim of my present study is to evaluate the functional outcome and the quality of life of patient aged above 50 years with a femoral neck femur fracture managed with hip arthroplasty and internal fixation. The patients and method, I included the patient who gave consent for the operation, had a displaced femoral neck fracture, are aged above 50 years and have independent ambulation before the injury, are included in the study, while who gave refusal to the consent are aged below 50 years and having pre-existing hip pathology are excluded from the study. The patients are fixed either with the internal fixation or with the hemiarthroplasty. The patient who have whole neck of femur fracture with the absorbed neck and viability of head is jeopardized are operated with hemiarthroplasty. The 100 patients are allocated into two groups, one into internal fixation and then another into hemiarthroplasty. The internal fixation group included the fixation method of conventional CC screw pattern with inverted triangle technique or a BDSF technique or a DHS, while the hemiarthroplasty patients were treated with a cemented bipolar hemiarthroplasty with these two approaches. You can see the ancient techniques of two approaches of hemiarthroplasty and a post-operative radiograph. Here you can see intraoperative C-arm images of internal fixation fixed with inverted triangle technique and the BDSF technique. The follow-up protocol of both the methods were as usual, but in case of in terms of weight bearing and hemiarthroplasty, the mobilization protocol included mobilization as early as 3rd to 4th post-operative day with partial weight bearing and as tolerated with use of crutches and walker up to 6 weeks, then full weight bearing. In internal fixation, the weight bearing was allowed as it was possible depending upon the pain, initially with support and then without support. In functional outcome, we evaluated the functional outcome of both these methods in terms of Harris-CP scoring system. You can see in hemiarthroplasty, almost 88% patients had fair to excellent Harris-CP score, while only 7% patient had poor. While in case of internal fixation group, 34 patients of internal fixation had poor Harris-CP score at the last follow-up of 6 months. Table depicts the comparison of Harris-CP score at the follow-up dates of 15th, 3rd post-operative month and 6th post-operative month following this fixation method. As you can see, only 4 patients of hemiarthroplasty resulted into poor RSAP score at 6 post-operative month, while 14 patients of internal fixation resulted into poor RSAP score at the last follow-up of 6 post-operative month. In terms of mortality, blood loss, duration of surgery, and revision operation, in mortality and duration of surgery, it was almost the same in both these methods, while in case of blood loss, it was around having a mean difference of 180 ml. The overall reoperation rate was 5.5% in hemiarthroplasty group, while it was more than 20% in internal fixation group, making it a risk factor for major reoperation in internal fixation. The cases showing the follow-up images following hemiarthroplasty, the clinical images showing the functional range of motion of a patient following hemiarthroplasty, cases fixed with internal fixation and inverted triangle technique. As we discussed the complication of both these methods, the healing related complication demonstrated significantly more often in patient with allocated to screw fixation group. These complications were fixation failure, non-union, and osteonecrosis. While there was no significant difference in terms of deep infection rate and mortality, and the average infection rate of around 4% was found in both these methods, the overall complication, as we calculated, was found to have 47% in cases who were allocated to internal fixation, while it was only 11% for the cases who were allocated to hemiarthroplasty. In the table, it is clearly shown that non-union rate of 33.5% was present there in the patient following internal fixation, while implant failure of lateral migration of the screw and non-union and avascular necrosis of even in the cases who were united following the internal fixation head was a rate of 9% following the fixation, making it a total reoperation rate of 20% in cases of internal fixation. In hemiarthroplasty, you can see the deep infection rate and other complication following the hemiarthroplasty are not so significant, while in case of hemiarthroplasty, the revision operation rate were 5.5%. A preoperative radio of a patient fixed with BDSF technique. You can see in the following images. Yes, sir, I'm going to conclude.
Yeah, please conclude.
You can see in the post-operative images, you can see the union of a fracture. While after follow-up of 5 more months, you can see the development of AVN in the femoral head following internal fixation. Another radiograph showing the lateral migration of screw and implant failure following the BDSF technique. Another radiograph, post-operative images, other images showing the lateral migration of the screw and non-union following the internal fixation. A BDSF technique showing the internal migration of a screw into the joint following BDSF that was revived with hemiarthroplasty. A patient with the internal fixation showing the non-union. Another case showing the AVN following internal fixation. A case of hemiarthroplasty showing the prosthetic hip dislocation following hemiarthroplasty. As you know, the optimal surgical treatment is a debatable topic. Nevertheless, numerous randomized studies have provided the evidence of better functional outcome following hemiarthroplasty as compared to internal fixation in terms of overall functional scores, abductor muscle functions, and independent ambulation without walking aids, and adding the quality of life of the patient. Although perioperative blood loss and length of hospitalization were significantly lower in terms of internal fixation, while in patients of post-operative functional score, it was as it was evaluated up to 8 months of evaluation and need of reoperation were in favor of hemiarthroplasty. In conclusion, I would like to say that the present study showed that hip arthroplasty compared to internal fixation for the treatment of femoral neck fracture significantly reduces the risk of reoperation at the cost of higher superficial infection and blood loss. Furthermore, post-operative function as evaluated by the Harris-AP scoring system was significantly higher in hemiarthroplasty group compared to internal fixation up to 6 months of evaluation. Thank you very much, sir.
Parallel cases chalte the. Hello.
Yes, sir.
Dr. Anup. Dr. Anup, can I speak?
Yeah, please speak.
Please, Dr. Saket, please.
Yeah, good afternoon, everyone. I'm Dr. Saket Jati. I'm the secretary of MP chapter of Indian Orthopedic Association. And first and foremost, thanks a lot to the UP chapter, specifically my contemporary and dear friend, the postgraduates to take part in the UPCon, because this is a prestigious moment for the postgraduates. And I convey my regards to the Vice President of Indian Orthopedic Association, Dr. Shirvastav, Dr. Jamal Ashraf, and the President, as of now,
Sanjay Dhawan now.
In UP Orthopedic Association. And now, my dearest friend, Dr. Sanjay Dhawan, because a change of color took place yesterday.
Yeah.
So, aap sabko salute, and I'm in Patna in GovCon, and we had fantastic academic feast here. Regards to you. Thank you so much, Anup bhai.
Thank you, Dr. Saket. It's really a pleasure to have you on the board and your fellows. They had presented wonderfully. Both the topics were good. And I'm happy that we are sharing the knowledge through this exchange fellowship. And we'll continue this sharing of knowledge amongst MP chapter and UPOA. Thank you, Dr. Saket, for giving us this opportunity.
Thank you so much, Anubhai. I'll just take 15 more seconds. I invite all the esteemed seniors and colleagues to the MP ICON 2021 at Bhopal on 16th and 17th of October. I'll keep you posted. Stay blessed, stay safe. Regards, Anubhai. Thanks a lot. Sanjay bhai, regards.
Thank you. And let me take this opportunity to thank all my speaker, all faculties, panelists, moderator, and moderator for this, Dr. Ajay Singh, Dr. Imran Akhtar, and a special thank you to Johnson & Johnson for sponsoring and taking care of this whole webinar, which we had it on the UP OrthoCon. Thank you, Meenakshi and Sutirtho, for taking time out to join us and for taking this academic initiative by sponsoring the whole academic event of UP OrthoCon. And a very, very special thank you to Joint Secretary UPOA, Ravi Khanka, who was also there holding it on the laptop since 8:30 a.m. and still he hardly had a cup of tea, I think. Thank you, Ravi. Keep it up. And thank you, Sutirtho. Meenakshi, thank you. Thank you, Dr. Ajay, Imran. Thank you, everybody. It was a wonderful show from all of you. Thank you.
Thank you.
Thanks a lot,
Thank
sir.
you, sir. Bye-bye.
Thanks. Bye-bye, sir.
Thank you very much, sir. Ending the meeting now.